Welcome, everyone. My name is David Grady, the Regional Manager for the State Council on Developmental Disability Central Coast Region, and I'm your host for today. We are so pleased to have you here at Bridging the Gap, a behavioral health symposium for people with IDD. Before we get started, let's go over some housekeeping. Sheridan, can you review Spanish interpretation and closed captioning?
Yes, I'd be happy to. Welcome, everybody. Good morning, and thanks for joining us at this symposium today. Much of our discussion is based on the belief that people deserve access and equity, and we are working to provide that for attendees that attend this event today. Today, we have CART services, communication access real-time transcribers, otherwise known as captioning services. We have Spanish language interpretation and American Sign Language interpretation. Let's cover a few important details today. First, I will pause for our Spanish interpretation specialist, Stella, to get us started.
Buenos días a todos. Gracias por asistir hoy día. Estamos comprometidos al acceso igual para todas las personas y queremos señalar que voy a repasar
las instrucciones para los diferentes tipos de instrucción. Okay.
Wonderful, thank you. Captions may be viewed either on the stream text link that we will put in the chat in just a moment, or using your CC button in the Zoom controls of each user at the bottom of your screens.
Los subtítulos se pueden ver ya sea por el enlace que vamos a poner en el chat en un momento, o si no, el botón que dice CC en la barra de controles de Zoom.
Great. We're providing simultaneous interpretation, so everyone here today will need to, in a moment, select your language channel by clicking or tapping on the globe icon and selecting either English or Spanish. You must choose one. If you are bilingual, you can switch languages by pressing the other language button, and that will come up in just one moment.
Vamos a ofrecer interpretación simultánea al español hoy día y cada persona debe de seleccionar un canal de idioma. En un momentito van a ver el globo, el icono de interpretación, y cada persona debe seleccionar ya sea
el inglés o el español. Las personas bilingües pueden cambiar de un idioma al otro, así como gusten.
And if you select the Spanish channel, please, you may also select the mute original audio so that you only hear the interpreter. And if you choose the English language channel, do not mute the original audio, otherwise you won't be hearing anything. And please note that your planning team is working to complete a Spanish translation of the deck you will see today. The deck will be provided in English and Spanish after the event.
Si usted selecciona el canal de español, por favor, también seleccione el botón que dice silenciar audio original, de modo que solo pueda escuchar el intérprete. Si está escuchando en inglés, no oprima el botón que dice silenciar audio original, porque si no, no va a poder oír nada. Y también las diapositivas se van a estar disponibles después de la conferencia, y el equipo está trabajando en traducirlas al español y estarán disponibles en inglés y en español.
Great. At this time, everyone should have chosen a language. Is everyone on a language channel? If you need assistance, you can post a question in the QA box, and we will respond using the QA feature, or we may share information with everyone using the chat function. Only panelists and administrators can create a new chat, so all guests, please use the Q&A box. We have been spotlighting our ASL interpreters for this symposium. This means that they should be viewable no matter who is presenting, and even when we are viewing films or presentation materials. You may also choose to pin your ASL interpreters and change the size of their screen as you see fit. And
Tenemos,
that's it for access and needs announcements. Back to you, David.
Thank you, Sheridan. And if your audio is sounding somewhat muted, that's because you still need to choose a channel. If you're English speaking, please select English. Spanish, select Spanish. And if you are bilingual, it's the choice is yours. Thank you so much, Sheridan. A link to today's program agenda was sent in yesterday's reminder invitation to this webinar. Refer to the schedule to get a list of topics and presenters. And this agenda is also located on our resource page. As you can see from our program, we have a full day. It's important we stay the course so we can cover all presentations and conclude at 1 o'clock this afternoon. So I'd like to review our webinar format. Audience members will not have access to chat. Rather, symposium organizers will use chat to inform us of important information, including webinar instructions and other important links. For all questions, we are asking audience members to use the QA tool located on the toolbar at the bottom of your Zoom screens. Please type in your questions in the open QA window. Presenters then can offer their typed answers in the same window. Toward the end of the day, there will be about a half hour for questions and answers with a panel of experts. They will be able to answer your questions. The questions will be presented by our question and answer administrators. They will come from a Symposium tech support team. And finally, we recognize that some of us may not get our questions answered today. We plan to take the questions added to the QA window, cut and paste them into a document, and create a FAQ that will be available on our resource page in the near future. Again, it's important we stay on schedule, and therefore our audience will not have access to their microphones or cameras. As you know, through a random selection process, we are awarding gift cards to some members of our audience. Winners will be announced in the chat window and informed by email. After today's webinar, we will send you a satisfaction survey. Gift cards will also be awarded to a random number of those who complete the survey. In the survey, we will have a question for anyone interested in working with State Council to address improving the integration of services. There is a section of the survey where you can state your interest and share information and an email address. The State Council will then follow up and reach out to you. Finally, we have a reference page. The link will be added to our chat window. This page includes a great deal of information related to behavioral health. On this webpage, we will post today's PowerPoint presentations, a recording of the webinar, and the results of our pre and post surveys, as well as our frequently asked questions document. Today, we are taking on an issue that is large and complex. It can feel overwhelming to individuals, families, providers, and clinicians. We have an impressive group of presenters, administrators, all dedicated to integrating services and supporting our community. We will inform this audience and all stakeholders in developmental and behavioral health services that people with intellectual and developmental disabilities often need and are to receive behavioral health services from regional center and county and private behavioral health services. This service is to be integrated care from qualified professionals aware of best practices in treatment that is most responsive to the person's immediate and ongoing needs. This sounds simple, but for those with developmental disability needing behavioral health care, we know this can lead to a person being stuck between two systems and getting no services at all. Today, we will offer a broad overview of departments, agencies, and service systems and their case management strategies to assure care. Much is happening, much needs to be done. And before we get started, I just want to extend my thanks to all those who've been helpful in putting this symposium together. we wish to thank our sponsors, Hope Services and Kaiser Permanente, as well as our expert group of panelists. Special shout out to Sheridan, my colleague over at the Bay Area Office for State Counsel. Also, let's give thanks to Nam Lee, the marketing director at Hope, who's been responsible for putting all this together and making sure all of us here at the symposium got the appropriate links to be here. And holding it all together is Courtney Berry, the executive assistant over at Hope, who is responsible for keeping the meeting scheduled and having all our planners show up on the same day for planning. So with that, let's get started. I want my friend Uday Kapoor to introduce our guest speaker, who is to welcome us at today's symposium. Uday.
Thank you, David. I'm a board member at NAMI Santa Clara County. And I have the distinct honor of welcoming a towering figure, an icon, and mentor to many, former State Senator Jim Bell, to this important symposium. A Bay Area native, during his 30 years in public office at the city, county, and state levels, he has been a champion and advocate for underserved youth, low-income families, and people facing mental health challenges. Through the passing of numerous landmark bills as a legislator, he has left his mark across the state. Welcome, Senator Jim Bell. So go ahead.
Jim, your microphone is muted.
How's that?
Yes.
Good? Okay. Today I want to talk to everybody as a former state senator, but also as a parent of somebody who has developmental disabilities and mental health issues. So as parents and practitioners, the program we have today will develop an excitement, I hope, and resolve for improving our mental health system for persons with developmental disabilities. I have long worked for and dreamed of an improved and responsive mental health system. We don't have it, but if we did have such a system, it would transform society and benefit everybody in the whole state, all 40 million. But if that's why I want to never give up on fighting for this, and that's why you should never give up. Now, why not have a prevention and full range of treatment programs and services for all? Now, as a goal of society, this sounds like a good idea to do. So I'm going to ask some questions and to elicit some thinking in this seminar that we're all in. Now, what if more people became mental health professionals with special training in treatment of persons with developmental disabilities, and were paid adequately, and their school and education subsidized? We need to have more professional staff. We need to have more service staff. The payment has been a problem. We need to have the best and brightest recruited to help all of us. What if the mental health system was improved? It actually improved families and reduced poverty, incarceration, and substance abuse, addiction, and other disabilities. What if we had a full service mental health system? Now, I always say this. I always say hospitals and housing instead of prisons and jails. And what I mean by that is that it's much more cost effective and benefit for society if we build more acute care hospitals and also other housing options for people, which is an extreme shortage, rather than improve jails and build more jails and build and improve more state prisons. Let me give you an example. You know, the state prison had 34 prisons. I visited about 24 of them. I've gone to 24 prisons. A few years ago, I went to one prison, and there were people in brown costumes or brown outfits, and they had DD on the back of their outfit. And I asked the warden, I said, what is that? He says, oh, those are the developmentally disabled. And so I said, well, you're stigmatizing them. And he says, what am I doing? I'm just identifying so the staff knows who they are. Well, I think the prison, it kind of sunk in that prisons and jails is not a good place for people with developmental disabilities. So we have to look at transforming in our political environment, prisons and jails, and reduce the number of prison and jails. Governor Newsom has already talked about closing as many as 3. I think we can close 6, and we can use that savings that we have and apply it to acute care psychiatric facilities, residential facilities, and specialized treatment facilities. Because they say now that up to 40% of the state prison population, the sheriff just said 25%, I think it's a lot more in our county jail, are people with mental illness. So what if we, just ask the what if we had less prisons and jails and more acute hospitals and housing for people? Now, when I say hospitals and housing, I include addiction. The cost of homelessness is astounding. They haven't even been able to really get their arms around the cost of homelessness. A lot of the homeless people have developmental and mental health problems, but we don't have any kind of treatment or therapeutic program that is a consistent program. We're just throwing money at things. We're not dealing with it in a systematic manner. What if the education system took care of students with mental health problems at schools, and their education was improved? That is happening right now in Santa Clara County and elsewhere. They finally are allocating money for mental health services and youth programs in the schools. So that's the good news. What if we had more control over toxics and things that cause developmental disabilities in our environment, and a better control and understanding of that, so that we'd have less children born with developmental disabilities due to toxics? What if we studied that? We haven't even got any semblance of a good study on that subject. So we need to do that, because if people are putting toxics into our environment and affecting our children, it seems to me that we ought to make them liable for the toxics and the impact on our kids. Now, what if the Latterman Act goals were achieved and the barriers created by stigma and discrimination eliminated? So I kind of like to use the word discrimination. Stigma, yes, there is stigma, but it's really, what it is it's really discrimination. It's discrimination in a civil rights sense. So I think we have to look at it as discrimination. Now, you may think all of this is impossible to achieve. I think we have to achieve it. It's an urgency matter, and it's just a matter of shifting to spending. It's not a matter of increasing the spending. We can cut down the prison budget, the jails budget, and increase these other areas. And by the way, it is something I've studied quite extensively. I've served as chair on the finance or budget committees in over a 40-year period on the state Senate, the state assembly, the board of supervisors, and the city council in San Jose. And you know, it costs $110,000 to put somebody in a state prison system, maybe $30,000 more if they have a mental health or disability in the system. No therapeutic results have been proven there. The state hospitals is about $300,000 per year. Emergency treatment in a hospital, $25,000. I think our Department of Developmental Disabilities, I'm not sure, it's about $25,000. You know, so you can see it's a lot less than prisons. School districts spend billions on special education. A lot of it's spent on lawyers and administrators rather than direct services for the kids. The cost to society of mental health is staggering from an economic standpoint. It impacts poverty, foster care, aging, education, achievement, healthcare, makes our healthcare system not work right. The COVID situation has made it even worse. If you add it all up and include homelessness, and it looks like society, we are paying a heavy price. So if we are paying such a heavy price morally, socially, economically, and health, why can't we begin to change in a more fundamental way? And we have to have courage, determination, and resolve to do so. So breaking down the barriers and setting up a new direction is hard. It's really difficult, but it must be done. A lot of people are depending on us, so let's do it. Now, President Barack Obama said the words of hope we need, yes, we can. And we can do it, yes, we can. So let's shift the priority of our spending and let's look at those return for our investment for a positive society that we want to have and reduce the costs in so many areas by making a better system and a better life result for people. That's the intention of the Latterman Act. We should continue to follow that intention.
Jim,
and I thank everybody for
thank
their
you,
attention.
Jim. That was excellent. And those are exactly the questions that we are hoping to address today. Purpose of today's Bridging the Gap. So I really appreciate you giving us this welcome. And we'd now like to turn it over to our keynote speaker. We're delighted to have Uday Kapoor from Kaiser Services. He's works over there and has been instrumental in helping Kaiser move toward integrated services for both healthcare and behavioral healthcare. Doctor, glad to have you. Thank you.
Thank you so much, David, and thanks to Senator Beal for that great kickoff. Good morning and welcome to Bridging the Gap. On behalf of Hope Services, all of our sponsors, panelists, and participants, thank you all for joining us as we begin this critically important conversation about supporting some of the most vulnerable and challenged of our families and communities, those with intellectual and developmental disabilities, co-occurring with behavioral and mental health problems. My name is Uday Kapoor. I'm an assistant medical group administrator with Kaiser Permanente in Santa Clara and a proud member of the board of directors of Hope Services. By training, I'm a licensed clinical psychologist who's been practicing in the mental health field for more than 30 years. My career started in the late 1980s, working with children with developmental disabilities and intellectual disabilities with co-occurring emotional, behavioral, and mental health disorders and their families. My objective this morning is to give voice to the clients, their parents and families, providers and caregivers who have bravely and courageously traveled this path with all of us over the years, to talk about how far we've come as a community and how much farther we have yet to go on this journey. And if you'll permit me, I'd like to start with the story of Sam. My brother-in-law, Sam, was born in the North Bay in 1959 to my mother and father-in-law, Saul and Judy. who could not have been more excited and thrilled to welcome their firstborn child into their lives. Many of you can relate to the hopes and dreams they had for Sam, watching him grow, thrive, take up hobbies. Perhaps he'd grow up to be a great musician or artist or athlete. They dreamt of the beautiful life they would give him, the graduations, proms, events, maybe a wedding, eventually grandchildren. Within the first year, Saul and Judy noticed Sam had a lack of eye contact, smiling, social and emotional reciprocity, was difficult to soothe, and demonstrated poor and inconsistent sleeping patterns. Feeling very worried that their baby wasn't responding and developing in the same way that their friends' children's were, they sought help. Sam's pediatrician assured my in-laws that babies develop at different rates and that there was nothing to worry about. When Sam became a toddler and then a kindergartner, however, it became very clear that he was behaving, reacting, and communicating in ways that were not consistent with his peers. And so began their long, painful, lonely, and frustrating journey. Saul and Judy were told regularly by teachers that their son was, quote, weird, odd, strange, a troublemaker, a loner, lacked empathy, and was poorly behaved. Doctors, specialists were consulted and all had different opinions, advice, and guidance, all of which focused on the implication that if these parents just parented better or differently, and if Sam just tried a little harder, all would be well. Blame and responsibility for the fact that Sam was not improving was placed solely at the feet of his exhausted parents, who felt an overwhelming amount of guilt and shame as a result. As Sam got older and his behaviors escalated, school officials quickly began disciplining him on an almost daily basis. Soon the detentions and suspensions began with ever increasing frequency. And as Sam's struggles with impulse control and emotion regulation intensified as he got older and as he entered high school, disciplinary interventions began to involve calls to the local police as anger outbursts towards students, faculty, and property became more commonplace. As you can well imagine, Sam was bullied and ostracized by his peers throughout his educational experience. Sam's parents were in great pain, forced to watch all of this unfold, helpless and at an utter loss as to what to do. In those days, there were no referrals to be made to local support services or agencies. There were no referrals made to a private psychotherapist or a psychiatrist. Sam and his family were essentially adrift, forced to passively react to each crisis, conflict, and outburst as they came along. There were no assessments and no guidance offered as to how to understand or even discuss these challenges with Sam, save one, the much lauded Stanford Binet IQ test. First published in 1916 and revised many times since then, it was once the singular method of assessing student ability and potential when Sam was a child. Sam tested in the gifted range when he was 5 years old. And for the next 13 years, his IQ was used as a reason or an excuse for denying him any and all supportive services within the school system. As Sam moved into adulthood, he had no experience with therapists, case managers, or supportive services, and very little reason to trust anyone, as most of his experiences with adults and the system outside of his family had been punitive in nature. As more services became available in his community, efforts were made to connect Sam without success, as he refused to participate. As an adult, Sam had no legal guardian, no conservator, and therefore full authority to make his own decisions about his medical and mental health care. Adulthood began another painful phase for Sam's parents and family, as they really had no control over what happened to him and no way to protect him from an indifferent and uncaring world. This dynamic has remained firmly in place until this day. There have been countless attempts and false starts over the years, but Sam remains steadfast in his belief that he doesn't need help. He's now 62 years old. His parents are both deceased. He lives alone, eats all of his meals out, mostly fast food, is socially isolated, and has never been able to successfully engage in meaningful work of any kind. His care is left up to his sisters, who do their best to visit his home, help him clean, and try to help him stay consistent with his daily living skills. What the future holds for him in terms of his care as he gets older is an unknown at this point, and a tremendous source of stress and worry for the family. You may be wondering about Sam's diagnosis. We wonder about that as well, but given that he was never assessed as a child and that he has refused to consent to a comprehensive evaluation as an adult, we can only speculate. What is irrefutable is that Sam's life would have been qualitatively better, without a doubt, if he and his family had been offered something, anything. But in the late 1950s and 1960s, there was nothing. No services, no understanding, no empathy, no support. Nothing would please me more than to be able to stand here today and report to you all that by the time I began my career in mental health in the late 1980s, many, if not most, of these gaps had been addressed and corrected. Yet that wasn't the case. While the realities on the ground were still immensely challenging, we had made significant leaps forward in research, assessments, diagnostics, and supportive services in those intervening years. It was at this point that I began my career while still a student, working in alternative recreation programs, independent living programs, group homes, respite care, and in-home skills instruction for children and adults with developmental and intellectual disabilities and those on the autism spectrum. Back in those days, I worked directly with clients, their parents, families, and caregivers. What I witnessed on a daily basis inspired and amazed me to such a profound extent that that impact stays with me until this very day. What I am referring to is the tireless dedication, commitment, and devotion these parents and caregivers demonstrated every minute of every hour, of every day, of every month, of every year, year after year after year. No matter how significant the challenges, no matter how dire the circumstances, no matter how severe the medical, social, educational, emotional, and behavioral challenges were, these unsung heroes, these inspiring, wonderful, and amazing people never, ever quit, ever. They kept pushing and asking and researching and fighting for everything they could think of to get the help, support, and resources for their child or family member. I would often see them at the end of yet another exhausting day, chocked full of tantrums, outbursts, doctor's appointments, meetings upon meetings, phone call after phone call, and whatever additional trials and tribulations they endured, only to wake up and do it all over again, never wavering from their unshakable commitment to give their loved ones everything they possibly could for a good quality of life and a hopeful future. As we fast forward to the present day, again, nothing would make me happier than to be able to stand here and announce to you all that we're all done. The gaps have all been filled, that families and clients finally have all of the help, support, guidance, and resources that they need. I don't need to tell you that we are certainly not there yet. But what I have seen in the many years since the early start of my career fills me with hope and excitement for the future, because we have learned so much in the last 30 years. ABA therapy is just one example of a tool we didn't have back then. We've also made leaps and bounds in the field of brain science. For an example, there has been some fascinating research out of the United Kingdom in the last few years that has shown that using transcranial magnetic stimulation, or TMS, which is a non-invasive medical treatment for refractory depression with children on the autism spectrum, may improve social skills and the ability to better pick up on social cues. While much more research is needed in this area before we roll this out as a standard treatment modality, it is certainly a hopeful and welcome development. Perhaps the most important lesson learned in the last 30 years is the need for an integrated approach to care and service delivery. Integrated healthcare has been defined by the American Psychological Association as, quote, the collaboration between health professionals to provide complete treatment to patients and improve overall well-being, and is characterized by a high degree of collaboration and communication among health professionals. What makes integrated healthcare unique is the sharing of information among team members related to patient care and the establishment of a comprehensive treatment plan to address the biological, psychological, and social needs of the patient. The interprofessional healthcare team includes a diverse group of members, physicians, nurses, psychologists, and other health professionals, depending on the needs of the patient. This concept of integrated care was not only a welcome change, but revolutionary, because we had a healthcare system that historically had been very siloed. But we quickly discovered that while having providers and caregivers from various disciplines communicating with one another on a regular basis didn't go far enough. Through organizations like Kaiser Permanente and many others, we found that housing all of our services under one roof, under one umbrella, not only improved collaboration and communication among providers, but reduced the number of places, people, offices, and phone calls patients and families had to navigate. It seemed like maybe we finally figured out how to reduce the number of hoops and barriers. Perhaps we did, just a little bit. But there is so much farther for us to go, so much more that our clients, their families, our caregivers, and professionals need. We must acknowledge that even today, our clients and families still feel lost and overwhelmed. And as a community of professionals, we hear you and we know that you feel lost. While the system continues to be frustrating and fraught with challenges, we must not give up or lose hope, because we are all here to help. While we know there is room for improvement, what hasn't changed in all of these years is a commitment, tenacity, passion, and determination exhibited by our clients, their parents and families, physicians, therapists, and all of the inspiring professionals who fight every day to make their lives and the lives of others a little better. A sincere thank you to all of you for joining us today for what we all hope will be an inspiring, informative, and hopeful conversation. Thank you.
Ori, that was great. As professionals, we are here to help. That is the hallmark of your presentation, and I think you clearly addressed and explained the reason we're here today and the need of the ongoing work that has to happen. I'm now excited to turn this part of the symposium over to the behavioral health team and staff of Hope Services, who are going to discuss the complexity of behavioral health care for people with intellectual and developmental disabilities. I'm honored to introduce Chip Huggins, from the Executive Director at Hope, and he will have his team to review this issue and get us moving forward in making changes. Chip, it's all yours.
Dr. Covey, thank you so much for that very inspirational keynote speech. We're so blessed to have you on the board of directors at Hope Services, and your work and support of what we do day in and day out. I must say, going back to March 4th, when David, Kathy Bouchard, and Ana Fernandez and I met on the phone and said, why don't we do a symposium? It's much needed. There's so much information that's missing. that we can help struggling families look for the services and the help that they need. And so with David's inspiration, we got behind him and collected a whole group of really interesting panelists and people who are serving in the Bay Area. And I look forward to going through today's symposium and learning a lot myself, because there's so much to learn. There's so much unknown and so much more work to do in this field. Again, thank you, David. And just a few words about Hope Services. We've been around 69 years. We've been servicing the DDI population for all that period of time. We started about 22 years ago serving behavioral health clients that have a co-diagnosis. We're the largest provider of those services and growing every month. We're about a $60 million budget and provide services to about 3,800 individuals. And we're expanding, which is reflective of how many clients are in need in our community. Go through the first slide, please. So this is generally, I'm going to give you a general overview and then turn over to my team and rock stars at Hope Services, which I'm so blessed to work with. But as we know, about 40% of people with DDI have a psychiatric disorder compared to 27% of the population. So we know that quite a few individuals with autism on the autism spectrum have bipolar and depression and symptoms. Next slide, please. As we know, symptoms of mental illness often present differently in individuals with intellectual disabilities. 10 to 20% challenging behavior, self-injury, aggression, destructive behavior, severe enough to actually impair daily life. Many of the clients that we serve are sometimes underdiagnosed, not treated, or the clients coming to us are inappropriately diagnosed. Symptoms of mental illness come through different ways in regards to the DDI population, and determining an accurate psychiatric diagnosis becomes especially difficult as the level of intellectual functioning declines. Next slide. And they present differently, as we know, and have to be dealt with differently. And having trained clinicians to be able to serve these clients is challenging, because there are not a whole lot of trained clinicians that we can hire and provide these services. And we heard a little bit later from our director of behavioral health, Anna Fernandez, about her challenges running the behavioral health clinic and providing those services to this population. Next slide. It becomes especially difficult as the level of intellectual functioning declines, as we've seen over the years. And so again, getting the right diagnosis is very challenging, and providing those services to the clients and their families. Next slide. I'm blessed to be able to work with some rock stars at Hope Services, and early interventions is critical in regards to our first program, which is the Home Start program. Our director of Children and Family Services, Hope Services, at Hope Services, Vicki Perkins, is going to talk about early intervention and some other areas in regards to stigma. Vicki?
Thanks, Chip. Good morning. Today I'm here to talk to you about early intervention services and stigma. While I plan to share a broad overview of these topics, it's important to note that I will also directly reference the children's program Home Start at Hope Services, for which I oversee. Okay, so when we talk about early intervention, what we're really referring to are the services under the Early Start umbrella for children birth through 3 years of age in California. Early Start is covered under Part C of IDEA, the Individuals with Disabilities Education Act. Anyone can refer a child for an assessment for consideration of services but parents must consent to the assessment before it can be completed. They can contact their local regional center or call the 800 number on the DDS website for an assessment. Upon doing so, a child's motor, adaptive, communication, social, and cognitive skills will be assessed. Young children are found eligible for early start services if they have an established risk factor, are at risk for developmental delay, or are falling behind 33% or more in one area of development. If they qualify for services, an individualized family service plan, IFSP, will be developed. This is a legal document that outlines the child's areas of strength as well as their areas of need. It also documents parent resources, outcomes, and services. Once an IFSP has been established, the regional center will refer children to programs such as Home Start. Services that programs such as Home Start offer are specialized instruction, occupational, speech, and physical therapy, along with social work support. There are additional services that are covered under the Early Start umbrella, as noted on the DDS website. Our goal at Hope is to partner with and empower families so that they have the necessary tools to understand and help facilitate their unique child's development. Early intervention utilizes a parent coaching model. Because of this, it's imperative that we establish positive working relationships with families enrolled in our program at the onset of services. Our program employs evidence-based practices. We use a family systems theory approach to working with our clients. We understand that our clients are one part of a family unit, and we must work collaboratively with the family in order to effectively support them. Because we work with such young children, oftentimes we are the first face of support that a family encounters. We work with a wide range of families in terms of cultural background and socioeconomic status. Some families are leery of the system and don't believe in securing help for developmental disabilities or behavioral health challenges because of previous experiences and/or negative feelings stemming from cultural beliefs associated with a given diagnosis. What we do in this situation is we try to meet each family where they're at. What does this mean? It means that some families are grieving the loss of the child they always envisioned and may be experiencing different emotions associated with a new diagnosis or concern related to their child's challenges. Other families might be reluctant to seek help because they're nervous about what a label on their child might mean for their future. I can't tell you how many times a parent has said to me, please don't share my child's diagnosis with the preschool or the daycare provider or the soccer team, because they're so worried that their child's going to be treated differently. When we run into these concerns and challenges, we try to remind parents and reassure them that we're here to support them in whatever capacity we can to help their child to reach their potential. We try to focus on their concerns and priorities versus a label or a diagnosis. Approaching families from a strength-based perspective helps them to see that we believe in their child and acknowledge all of the great things that their child is already doing. These families need someone on their side, and we're here to be those resources. We try to be very sensitive and intentional with each and every family we work with in order to build a trusting working relationship. It's imperative that service providers understand that each child is an individual and their family is a unique entity. While many of the Home Start team members have completed training in infant, child, and family mental health, we do come across situations that warrant more support than we can offer. Part of our role as early intervention providers is to connect families to community resources. It's important that we identify areas of concern that are beyond our scope of practice and make the appropriate referrals to further support families enrolled in our program. When a client of ours presents with early signs of a behavioral health challenge, we often encourage them to check in with their service coordinator at the regional center, their pediatrician, KidScope, and/or Parents Helping Parents for further guidance. In this process, we aim to assist families in accessing the supports and resources that are available but unbeknownst to them. Sometimes our families just don't know there's help out there for them. Helping families to navigate the system is the responsibility of all of us in the field. We must remember we are privileged to play a role in our client's journey. Families deserve to know what supports exist and how to go about securing them. Increased collaboration amongst all disciplines will help us to more effectively serve our families in the community. And in closing, I'd like to echo the words of Henry Ford. Coming together is a beginning, staying together is progress, and working together is success. Thank you. Next up, it looks like Robin Miller is going to join us.
Hello, good morning. Thank you everyone for your presentations. They've been very enlightening. I am asked to speak about transition to adulthood planning for students with disabilities. And I just want to start with a little bit of background. The next slide would be good. I am specifically speaking about transition planning for students with individual education programs. They receive special education because they need specialized support and instruction to benefit from their education. And I'm not going to go over all the details because of limited time, but you'll get this slide and can feel free to contact me with any questions. I just want to go to the next slide. I just want to emphasize that it's important if you think a student needs an IEP or needs more in their IEP, regardless of their age, even if they've never had an IEP and they're now in high school, you should refer them for an assessment or evaluation. They mean the same thing in special education lingo. The school district has an obligation to assess any student suspected of having a disability regardless of age. So they should be pushed on that. And now I'm just going to go back to my topic. So the next slide would be great. So transition planning. By law, the students who has, by the time the student turns 16, they should have an individual transition plan within their IEP. And that can actually start anytime. It could start in middle school if you can think of things that they need toward adult planning, but by the age of 16, it must start. And the transition plan, which is literally a couple pages part of the IEP and should be part of the discussion in the IEP meetings and part of the assessing and support that students receive. The transition plan can cover 3 areas: education, employment, and independent living. Education for students planning to go to college or maybe a training program that's with a community college. Employment is for preparation and training related to career interests, and independent living for any independent living skills a student might need. These independent transition plans should have 3 elements: post-secondary goals, short-term IEP goals to reach the post-secondary goals, and IEP services, activities, or community experience that's aimed at reaching those post-secondary goals. So I'm going to talk about this for a few minutes. So you can go back to the last slide. Sorry. This is the main slide for this presentation, actually. So the post-secondary goals are literally the goals that the student would have for their adult life. I want to attend community college and pursue a career in music, or I want to live independently from my family, work with food, and pursue recreational interests. And if they want to work, or that's sort of the plan for their life, but they don't really know what areas or maybe leisure skills that they don't really have developed yet, the goal can just be to research options or consider what they're interested in for 1 year, and then the next year they would get more deeply into toward that particular goal or setting the goal. So then IEPs, many of you know, have annual goals. Those goals are made toward meeting the student's educational needs, toward meeting their emotional needs, their social needs. With the transition plan, they need to add goals that are aimed at meeting the post-secondary goals. And I know the word goals comes up a lot, but that's just the way they do it. So these specific annual goals should be specific goals that the student will work on as part of that year of their IEP. They might be something like, for education, it might be learn about accessing disability accommodation to college, or self-advocacy goals so that they can do that when they get to college. Employment, it might be learn what requirements are needed to work in the particular career they're interested in. Or it might be what is required to get a license for that career, such as to be a beautician. Or it might just be learn about my skills and strengths so that I can learn about careers that where I would likely be successful. In independent living, the annual goals might be learn how to use the bus system, get around in my city, learn about nutrition or how to shop for food, or how to prepare meals, or even leisure skills training, just learning about different recreational options and what I might want to do with my leisure time as an adult. And then the services and activities piece would be things like having somebody supporting the student and their goals toward learning about what they need to do to reach their post-secondary goals, their career goals, or even learn about careers. Or it might be program enrollment in appropriate activities to get work experience. And there are programs specifically integrated into public schools, or else it could be involvement in a program that's outside of the school. And those kind of programs might help them gain experience just in understanding about showing up on time, taking breaks, calling in sick if needed, learning there's an employer manual with your rights and benefits. Or it could be specific experience toward an area they want to work in. There could be a program toward preparing for a licensing exam, could be travel training to learn the bus system, a class on nutrition. It varies widely. It just depends on the student's needs and interests. Okay, so now the next slide. How to figure out what to do for the student, or what the student wants to do, in part, or what to put in the transition plan really, in part involves assessment, assessing students' interests and skills. And I just list a couple of main types of assessment, but there's could be very wide. And I want to say that there's other systems like the Regional Center and Department of Rehab that also have programs supporting students moving toward their adult years. And best practice would be to coordinate these so that the student is working toward the same thing. And these different staff that they have access to can help them more effectively, I think, meet their goals. And I also want to mention that anyone can be invited to an IEP meeting, so that staff can come to the meeting as a way for everybody to talk to each other and plan together. And Department of Rehab in particular is required to attend IEP meetings if invited. Okay, next slide. So in addition to transition, there's the issue of when a student leaves school. IEPs last until the student gets a high school diploma, or until they turn 22, or until they just end it themselves. And they, at that time, when the IEP ends, the district needs to provide them with what's called a summary of performance. And I don't need to go in detail here, but just say that it's basically a summary of their educational experience and their accommodation needs and the disability, and the it can benefit them later when they're trying to get accommodations in employment or in later education. And it can also help them with vocational rehab, comprehensive assessment process. And that's and the next slide just shows you what's basically in the summary of performance. And then the next slide, I just want to remind everyone that when the student turns 18, it's their decision about their education. And sometimes they really don't like being pulled out for services for IEPs, or don't like something about it and they want to drop it. So it's kind of important, if you think their IEP is important and you think it's going to serve them, to help them understand how it's been helping them and how it helps them all along, really, while they're growing up, so that they can hopefully be on board when they have the time, become the age where they can decide what to do themselves. And in any case, they can assign decision making to the parent if they want to, for example, if they don't like going to IEP meetings. But I just wanted to point this out because it's important to have them ready for that age. And the last thing is there are agencies, next slide, where that provide free services. And I've listed them kind of by county. And last slide is just my contact information. Feel free to contact me with any questions. Thank you.
Good morning. I'm just going to spend a few minutes talking about stigma and mental health. It really is definitely has an impact, stigma, and as Senator Bell said this morning, discrimination. And stigma basically refers to the negative attitudes or discrimination against someone based on a distinguishing characteristic like mental health. And even though we've made great progress over the years, mental health is not looked at in the same way as other medical conditions. But we're moving along in the right direction. If you look at all the people who have come out, famous people, to talk about their own struggles with mental health, Christy Teigen, Demi Lovato, Michael Phelps, Chris Evans, Kendrick Lamar, Dwayne "The Rock" Johnson, so many people coming out to talk about it. If you could go to the next slide, please. There's different types of stigma, you know, the public stigma, what other people are feeling about somebody with a mental health, the self-perceived stigma, which is just the internalization of shame, embarrassment, and the institutional stigma, which Senator Bell referred to this morning, would talk about people who are in prisons with DD label on their back. That's just horrifying. Can we go to the next slide, please? There's a lot of research out there that is telling us about stigma. I don't want to go into all this. But basically, the thing that I found interesting is that stigma of mental illness is universal. It crosses all cultures, all different ethnicity groups, age groups. There is no difference. They're all looked upon differently. But the good thing is there's a lot of anti-stigma campaigns going on. If you can go to the next slide. Because really, stigma is all about fear and the lack of understanding. This is just a short list of all of the different anti-stigma campaigns. There will be more in the resource page at the end. But we have somebody here from our local area, and I'm going to welcome Sylvia Tang, who's here from Stigma-Free San Mateo County. If we could highlight Sylvia. She's going to share a little bit about what's going on in her area. And it's typical of a lot of things going on across the United States. Welcome, Sylvia. Thank you for joining us.
Great. Thank you so much, Kathy. And that was a really great introduction to stigma. And just, hi, everyone. Good morning. I'm Sylvia Tang. I use she, her pronouns. I work for the Office of Diversity and Equity at San Mateo County Behavioral Health and Recovery Services. I'll try to be brief. So if there are any remaining questions that come up, I'll put my information in the chat. But just really briefly, our Office of Diversity and Equity, we work in collaboration with community, and we aim to advance health equity and behavioral health outcomes of marginalized communities by influencing system change and prioritizing lived experience. And I personally work on stigma discrimination reduction work in collaboration with statewide efforts, and also on suicide prevention. So just a little quick overview of our campaign. I will add our website in the chat after I speak, but our campaign is called #BeTheOneSMC, and it started in 2013. And it's a communication campaign that's present in social media, and sometimes we do in-person pop-up photo booth stations as well. And the meaning of Be the One SMC is, well, formerly our campaign used to be called Anti-Stigma. So it was very clear what it was. But we thought that we wanted to make a more positive, proactive reframing of our anti-stigma campaign. So we called it Be the One SMC because we want to emphasize how we can each be the one to make a difference in reducing stigma around mental health and substance use issues in our county and beyond. So our campaign is targeted to San Mateo County, but it's really open to anyone who would benefit from it. So any of you, even if you're not in San Mateo County, you're welcome to check out our website and use any materials that are on the website. I also want to mention that a little bit of why we are doing this campaign. It's obvious, we're here to reduce the stigma, but why are we reducing the stigma? As many of you know, we're reducing the stigma on all those 3 different levels that Kathy was mentioning, at the individual, at the personal stigma individual level, and also at the system level, because we really want to encourage people at an individual level to get help, but also at the system level, we want the systems to support individuals in getting help as well. I also want to mention a little bit about our strategies and how we approach the Be the One SMC campaign. Research has shown that there's two key strategies around reducing stigma around mental health and substance use. If you like, I'm happy to dig those articles, but I'm just going to share, high level. Basically, the research says one of the key gold standard ways to reduce stigma is to be in contact with people who have stories of hope and recovery. So a lot of those names of people that we may know that Kathy was mentioning, like Chrissy Teigen or other people, they're sharing stories of hope and recovery. And it doesn't have to be a celebrity. It could be a fellow community member. It could be a family member. And that's what our campaign is trying to do. We're trying to show that there are real people and faces that are promoting this cause and also have stories of hope and recovery. The second key strategy to reduce stigma is around education. We need behavioral health literacy before we can to really understand what is it, so we can dispel myths about it, and that really helps reduce stigma around mental health and substance use. So, we're doing this campaign for reducing mental health stigma around mental health and substance use, but we're also cross collaborating with other efforts like suicide prevention and reducing stigma around that as well. We just did last year, 2020 in March, we did a baseline survey for our county and measuring the level of stigma in our county. So if any of you are interested in those results or you want to do it in your community, we're happy to share the information we did for that. But we got a baseline so we could see, what is our campaign helping reduce stigma in the future and other efforts we're doing in addition to this campaign. So I just want to also, so I'll end here and I'll add in the chat the website to the to our Be the One SMC stigma website. And I'll also add, since it's Suicide Prevention Month, September, I'll add a link to that as well. And I will also include my contact information. So thank you all for your time and attention and putting attention to this important issue.
Good morning, everyone. It's a pleasure to be here with you today. My name is Tara Beckman, LCSW and Chief Program Officer at Hope Services. As many of our presenters have highlighted this morning, the complexity of behavioral health care for people with IDD has many layers. To name just a few: coordination of care, accurate diagnosis, access to specialty care disciplines, and lack of integrated care all create challenges for this population. In order to staff programs like Home Start, we need to be able to hire physical therapists, occupational therapists, and speech therapists. In order to ensure clients have accurate diagnoses and improve access to effective healthcare, we need to provide adequate training for clinicians and psychiatrists. In the report, Medicaid Services for People with Intellectual or Developmental Disabilities, State Medicaid and Department of Developmental Disability Agency officials, as well as advocates, identified that among healthcare professionals, a low level of awareness about people with IDD and lack of understanding often creates barriers. These barriers sometimes often cause discriminatory treatment as well. Today, I want to briefly focus on the workforce challenges impacting IDD and behavioral health programs. I also want to touch briefly on training programs for providers to ensure that effective services are being offered to individuals with IDD. Additionally, I will talk about integrated service delivery models. I want to begin by highlighting the challenges of hiring and retaining direct support professionals. Next slide, please. The responsibilities of direct support professionals, DSPs, working with people with IDD are complex and require a range of skills. The role of many DSPs reach far beyond addressing basic activities of daily living and instrumental activities of daily living. While DSPs often provide personal care to people with IDD, they are also expected to facilitate engagement in the community, assist in skills development, and contribute to improved quality of life. As you can see by this slide, there are a lot of expectations of our DSPs, and those also include helping individuals to increase their independence, pursue individual goals, manage crises, and develop relationships in our community. Next slide, please. However, the high turnover rates, consistent vacancies, and low wages limit provider capacity and compromise quality of services. As you can see here, there's a significant shortage of DSPs in all service categories. Next slide, please. What are the implications of these high turnover rates and challenges with hiring? It affects the overall quality of the services provided. Tired workers make more mistakes. There's a lower tolerance of stressful situations. There's a substantial investment in overtime payout, and new staff results in less familiarity with client needs and symptoms. Next slide, please. However, there are opportunities. There are opportunities that we have to improve the quality of our DSP workforce, increasing wages and benefits, credentialing and competency requirements, and career letters and tiered compensation systems. Next slide, please. Next, I want to talk about the workforce challenges pertaining to lack of access, low level of awareness and knowledge of disability competent individuals that can result in individuals having a lack of understanding, which creates barriers to clinical care. Clinicians inadequately are prepared to engage clients. There's often a discomfort with challenging behaviors and difficulty identifying appropriate resources. Next slide, please. There are, however, opportunities, including comprehensive onboarding for new employees, experiential learning, and higher education coursework, ensuring that psychiatrists and counselors and clinicians have the training that they need to advance workforce capacity. Next slide, please. Next, I want to just touch briefly on integrated service delivery. Integrated service delivery is a result of a team of primary care and behavioral health clinicians working together with patients and families, using a systematic and cost-effective approach to provide patient-centered care for a defined population. Next slide, please. The benefits of providing integrated service delivery is that providers work in a coordinated fashion. They utilize the same framework for care and consistently interact with one another. This helps to reduce duplication of efforts and fosters more effective treatment and reduced costs. Next slide, please. Recommendations for integrated service delivery include education and training for our workforce, providing education and training programs on the diverse and often complex needs of individuals with IDD, looking at and re-examining our payment model for collaborative care and outcomes, examining our EHR systems and improving system integration, and encouraging our government to invest in EHR systems that create incentives to implement EHR systems system-wide. And of course, regulations. Regulations are often built around particular diagnoses rethought. We need to rethink and modernize these current regulations to ensure a seamless movement between systems. In summary, workforce challenges, including staffing and disability competent care, can improve if we invest in increasing wages, explore competency requirements, and provide career ladders and tiered compensation structures, advocating for training programs within universities and for current providers is also key to improving access in clinical care. Fully integrated service delivery models can help to improve coordination of care, clinical treatment, client outcomes, and access to services, not to mention reduction in costs. While there are some challenges, there are also a lot of exciting opportunities that we can all advocate for to help to continue to improve and enhance the services and supports for individuals with IDD. Thank you. I would like to now introduce Uday Kapoor.
Thank you so much. Thank you so much, Tara and the HOPE team. Just an example of the complexity of delivering services within our system by one of our providers. Uday Kapoor, a friend of mine, has been active in planning for today's meeting, and he has a special video to share. Uday, do you want to give a brief overview of the experience?
Thank you, David. As a parent, I feel very privileged for the opportunity to present a brief video narrative of my disabled son's challenging life. He will be 44 years old next week, and as a person with intellectual disabilities and a serious mental illness, schizophrenia, he needs sustained, specialized care, understanding, and empathy. Because of his extraordinary vulnerability, we, his aging parents, worry about his future care when we will be unable to advocate for him. I'm sure this is a concern of most families with these challenges. We, the community, owe these highly vulnerable fellow members our best efforts in establishing a system of care for their well-being. With that, let's roll the video. I recently saw an article about people with developmental disabilities and mental illness, where it was clearly stated that people with the dual diagnosis are the most vulnerable people in our society. My name is Uday Kapoor. I'm a board member of National Alliance of Mental Illness, and I'm here to talk about Samir, my son. When Samir was born, he had normal toddlerhood. He was walking and crawling and all that, but we noticed speech delays as he approached age 4. And it was later when we had him tested and determined that he had early onset of autism. At the time when Samir was being diagnosed, the science was not very well understood, and he was actually diagnosed as childhood schizophrenia. Because autism was not really coined as a word yet, they were still talking about pervasive developmental disabilities, PDD, or childhood schizophrenia. It was very confusing to us. We didn't understand it. In the beginning, we did not believe it. We were in denial, and we thought this is just temporary and that he will grow out of it. A lot of the burden of diagnosis fell on us as a family. So we had him tested at UCSF, and they determined that he had OCD and also ADD, and as well as Tourette syndrome. And again, there were no remedies, just having to go through as much therapy as possible. So my experience in helping Samir and raising him through all these years, I have developed certain skills where I understand the needs and the pain and the suffering of people like Samir. And it has caused me to have a lot of introspection and how I can help. For people that are attending this symposium, if you can help in any ways you can, and if you are one of the families that is suffering, I sympathize with you and I like to work with you, but we want to bring about massive change. This is one of the most critical factors in our society at this time.
Okay. Thank you, Uday. Just a wonderful video. Appreciate the Hope team for putting that together, Nam and your production crew. We're going to take a 5-minute break and return at 9:55 and shift over to the systems operations side of things, both the developmental systems offered by the regional center services and the behavioral health system offered by our counties, Santa Clara, Alameda, and San Mateo. So take a 5-minute break. Thank you. We'll be back at 9:55. And we are back. Really appreciate everyone's attendance today. We have over 300 people attending. This demonstrates how important this need is in the state of California. We have to understand the context, including what is offered by the regional center systems and the behavioral health systems. I am now ready to introduce the next slide, please. Our presenters representing Golden Gate Regional Center, and next slide, San Andreas Regional Center, both Mike Keeley, the Director of Consumer Services, and Lisa Rosine, the Golden Gate Director of Regional Center. Take it away, guys.
Thanks, David. This is Mike Keeley here from San Andreas, and I will introduce Lisa Rosine in just a couple of minutes. Thank you for letting us do this kind of brief presentation on the overview of regional center systems and participate in the symposium. I think that all of you here are going to get lots and lots of information. And what I really appreciate are the personal stories that people are sharing and the kind of the vulnerability and trust it takes to share your personal stories with us. And it also really brings things to life. It really brings meaning to the words. And I really do appreciate that. That being said, what I'm going to do is give you, Lisa and I are going to give you a brief overview of the regional center system. Many of you that are part of the regional center know about this already. And there may be some people, particularly with other areas like mental health, that might not know how regional centers work in terms of intake and eligibility. And it's really one of the most common questions that we get. So with that, I'm going to do maybe the first 4 slides, and then I'm going to hand things over to Lisa. Next slide, please. So we're going to talk about what are regional centers, who's eligible, what the intake process is, and the interaction with mental health services. I've been with San Andreas Regional Center for 25 years now and have gone through different portions of this. So let's start with what are regional centers. Next slide, please. So regional centers are nonprofit agencies that help support people with developmental disabilities and their families so that they can get the things that they need. They provide assessment, determine eligibility, offer case management, and they're funded by the Department of Developmental Services. Regional centers are primarily social work agencies. Each worker has a caseload that connects people with resources. The resources may already exist in the community, or they might be funded by the regional center. Each regional center typically has a case management division, which is the biggest part of regional centers, a fiscal division to pay our vendors and our staff, a community services division, which helps develop resources, and a quality assurance division. Next slide, please. So the regional centers were established in California statewide in 1966 to serve people with developmental disabilities and their families. And since 1974, regional centers work with individuals who are substantially disabled by cerebral palsy, epilepsy, autism spectrum disorder, and or an intellectual disability. There are 21 regional centers in California. Each one has its own geography. And there are right now a total of 329,000 individuals served by regional centers. So that's a lot of people. The largest regional center is Inland, and they serve about 34,500 people. And the smallest is Redwood Coast, and they serve about 3,900 people. So you see there's a pretty big range with regional centers. San Andreas serves about 17,300 people, Golden Gate about 9,300, and our other closest regional center neighbor is the Regional Center of East Bay, who serves about 19,900. An important thing to know is that regional center staff don't do the direct care for individuals, but we do case management and connect people with services. The regional center is not an office where people stay, although they can come and have meetings here. So a lot of times there's a misunderstanding that people say, well, just have the person go and stay at the regional center. Let them live there for a while. And that's not how regional centers work. The next slide, please. I'm going to go over a few principles and I'm going to turn things over to Lisa. So regional centers are private nonprofit corporations. Each follows guidelines under the Lanterman Act in Title 17. So I think in the chat, there were some questions earlier about, are there standards that regional centers use? And these are the basic standards that regional centers use to govern their agencies. Each regional center operates according to its own policies and procedures, and will have its own network of service providers within the community. Service design, rates of reimbursement, and regulations all come from the Department of Developmental Services. Next slide. So with that, I gave you a really sweeping overview of what regional centers are and what they do. And I'm going to turn things over to my counterpart, Lisa Rosine from Golden Gate Regional Center, to talk a little bit about eligibility.
Good morning, everyone. My name is Lisa Rosine, and I'm the Director of Regional Center Services at Golden Gate. We've already heard a little bit about the eligibility for people for regional centers. We do serve people throughout the lifespan. So we serve the little infants and toddlers under Early Start, and then at age 3, we serve people that have disabilities that are going to be lifelong. Next slide, please. To be eligible for regional center, the person must have 2 conditions. One, the diagnosis itself, but also information that the disability occurred prior to the 18th birthday, that it is most likely going to be a lifelong condition, and that it also is a substantial disability for the individual. And as Mike said, we are looking at intellectual disability, autism spectrum disorders, significantly impairing cerebral palsy, uncontrolled epilepsy, and other conditions that are closely related to intellectual disability and require similar treatment. These are defined in the law, and so they are incorporated in what we do in terms of determining the eligibility. Next slide, please. When looking at a substantial disability, the people doing the eligibility assessments are looking at how the disability is affecting the person's adaptive skills in the areas of self-care, receptive and expressive language, learning, mobility, self-direction, their capacity for independent living, and their ability to be economically self-sufficient. Next slide, please. There's some things to remember around the disability eligibility determination. And one thing is that a person may have a coexisting mental health diagnosis, but in order to be eligible for regional center, the disabilities cannot be solely psychiatric or learning differences or solely physical. The person can apply at any time, but the disability must have occurred prior to the age of 18. So we often are getting people now who are adults and may not have any documentation of a disability prior to the age of 18, and that makes the determination more complicated. Services are lifelong. If a person is eligible, they're completely voluntary. So we can't force people to accept services. People can start and stop whenever they choose. Next slide, please. Every regional center is set up differently in terms of how they handle the intake and referral process. Referrals can generally be made by calling the regional center, emailing. Each regional center has a website, and those websites have the information on how to contact the regional center. Typically, an intake specialist will complete a screening by phone, and they'll talk with a legal guardian. If the person is an adult and they're not conserved, they'll talk with the person directly. Once the regional center has all the pertinent information needed to move forward, we assign the case to a social worker, a case manager, who will do the social assessment within the first 15 days. Next slide, please. Mike, you want to talk about assessment?
Sure, thanks, Lisa. So here are some pieces to the assessment. The person will be assessed by a team of regional center staff, including a psychologist and an assessment social worker. The team may conduct further medical or psychological evaluations if they need to. Some of the records that help determine eligibility can be doctor's reports, school records, psychological reports, tests, family history, and the eligibility is completed within 120 days after they first see the person. Next slide, please. So some common services and supports that people get. I mean, obviously, when people come to the regional center, it's usually because they need some help with something. So once the intake process is finished, the planning team develops what's called an individual program plan, or an IPP, or the letters you'll hear a lot. This is a document that outlines the goals and the needs of the person and the outcomes for the future. And the IPP can be done every 1 to 3 years, although it's updated or redone. It can be updated or redone at any time. So if there's a change in a person's life, they just call and say, we need to make some changes here. And it focuses on the person. The person is the center of the IPP, and it usually has 5 primary categories: home and personal care, work, school and career, health and fitness, personal growth, recreation, and friends. Next slide. So a couple of guidelines here. The Lanterman Act is the primary law that outlines the roles and responsibilities of the regional centers. One rule is that, and this is the principle of the Lanterman Act, is that people with disabilities should receive everything that's available to them in the community, and they are entitled to extra services to support them. That means that community resources have to be accessed before using regional center funds. One thing that's interesting about California's regional center system is that we are the only place that's an entitlement system. There are waiting lists and things in other states, but not here in California. So, for example, a person with severe mental illness and a substantial developmental disability must be treated by behavioral systems as well as the regional center. They're entitled to getting both services. Regional centers are the funder of last resort and must make sure that other resources have been explored and used if possible. That's one of the roles of the service coordinator, is to connect people with all sorts of resources. Next slide. More common services the most common services are things that families need, like respite is one of our most common services, which means taking a break. Daycare, adult day programs, residential placement, behavioral support, transportation, case management, and independent living skills trainings. Those are some of the most common services that people get. Next slide. Support for people with mental health needs. I'm going to talk a little bit about this, and then I'm going to turn it over to Lisa, because as we mentioned, each regional center, although they abide by the same guidelines, they really work towards the services that are in their particular geographic region. So there might be some differences. Generally, some support for people with mental health needs include connection with behavioral departments, health service providers, regional center support providers. At San Andreas, we have Hope Counseling. We have that you heard from earlier. We have a program called START, which you're going to hear from later. We have crisis report services, CSS, crisis assessments we do. We have something called the STAR homes, which are homes that are available to all regional centers. There are locked facilities if people need them that regional centers can have access to, and community placement services and supports like supported living, enhanced behavior support homes, things like that, that are available to people if they really want them. Next slide, please. Lisa, you want to talk a little bit about maybe some supports at the Golden Gate and maybe talk a little bit about secure treatment?
So some of the individuals that are served by by the regional centers are referred to probate courts for involuntary commitments to a treatment facility because they are deemed by a court to be a danger to themselves or others. And there are a limited number of locked settings that are available for people with developmental disabilities. Community residential programs are not locked, and most of the state developmental centers have been closed. In order for someone who's served by the regional center to be in a locked facility, the regional center files a 6500 petition that the person is would be deemed to be a danger to themselves or others due to the developmental disability. And they cannot remain in a treatment facility for more than 13 months without a renewal. The regional centers cannot file 6,500 commitments. They only make the recommendation, and then the county's district attorneys file those. For the mental health side, there is an LPS, it's Lanterman-Petra Short, the legislation that established the hold. The regional center is eligible who is gravely disabled due to severe mental illness, and the treatment there is for up to 1 year, and it has to be again renewed by petition and approved by the court. Next slide, please. In terms of what is working, as Mike said, we have some services, and you're going to hear from a couple of them later on, specialty clinics that have been set up in counties in collaboration with the mental health services systems in those counties to serve people who have a developmental disability and a mental health disorder. And those clinics are highly effective. And then in terms of gaps, we need more of them. It would be ideal if every single county in the state was able to establish some type of specialty in this area so that people with developmental disabilities had ready access to needed counseling and mental health services. Next slide, please.
I think that's it for
Okay,
us.
oh, we're going on. I did just want to take a short, really there was a question in the question and answer about regional center services. And if anyone monitors the denials and the appeals and fair hearings. So yes, that is done by the Department of Developmental Services, and reports are given to the regional center executive directors and boards on a regular basis. And the other question was around uniformity. As Mike mentioned, we are all bound to follow the law and regulations, but because each regional center is a private nonprofit, the procedures may be a little bit different. So you can receive services once you're eligible for regional center. You can receive services anywhere in the state, but the availability of services may be different depending on where you are. You're going to find many more services available in urban areas and different types of services than you might find in a more rural area, you know, in far northern California, especially where transportation may be an issue. So it does vary from area to area within the state. Thank you very much for the opportunity to present to you today.
Thanks, everyone. David, I'll turn it back to you.
Yes, thank you, Mike. Thank you, Lisa. That was informative. It's such a quick overview. I hope it just gave you some highlights. And it's worth discussing more in detail if contacting intake coordinators at Regional Center or service coordinators or the State Council. We're here to help navigate through Regional Center systems as well. We'd like now to turn it over to how the county behavioral health systems work, and let us have Vanessa Baker from Alameda County Behavioral Health begin their portion of the presentation.
Wonderful. Good morning. Thank you, David, and thank you everyone who has presented so far. I'm certainly learning so much, and I'm very honored to be a part of this fantastic symposium. So we'll go ahead and start with the next slide. And we can jump ahead one more. So I am Vanessa Baker. I am a division director with Alameda County Behavioral Healthcare Services. I manage the older adult services in our county and also our Schreiber Center, which is our specialty mental health clinic serving those with intellectual and developmental disabilities and co-occurring mental health challenges. So what I'm going to do today is I'm going to review our mental health system so that everyone who is participating in this call has a really great understanding of all of the services that we provide throughout our county. Next slide, please. So first we'll start with what is Alameda County Behavioral Health, just to give that overview. So the Alameda County Behavioral Health and the older adult system of care, which is the system that I work in, serves adults 18 and over with serious mental illness that is moderate to severe, and those individuals, and sometimes with substance use, where those concerns seriously impact their day-to-day activities of daily living. Now that's a lot of words, but it's really important to recognize that, of course, as we know, mental health illness is not necessarily debilitating. Neither is intellectual or developmental disabilities. But what's key is that they have to really impact someone to the point where they are not able to manage without the support that our services offer. We have a very robust substance use division, and that's really important to know that they serve mild to severe. So there are different pieces in terms of the criteria. We serve individuals who are Medi-Cal recipients, Medi-Cal eligible, those who are what we call Medi-Cal and Medicare recipients, or those who are Health Pack recipients. So that's a specific type of service for individuals who do not meet full scope Medi-Cal. So we are a mental health plan, and each county has a mental health plan, and we're responsible for providing or facilitating services for those who meet specialty mental health criteria for individuals who, as I shared, meet Medi-Cal requirements. So specialty mental health services, I'm going to make sure I actually say the full terms. It means that the impact of the condition, as I mentioned before, is severe enough for that individual to require services of a specialist, as opposed to a generalist in mental health. So it's very specific criteria. So that's an overview of the mental health plan. Next slide, please. So I'll talk a little bit about accessing our services, screening and referral. Please move through the slide, the different pieces will come up. So we have a telephone screening process. This is used to determine if an individual requesting services meets the criteria that I just mentioned before for specialty mental health services. There's also an insurance coverage criteria review. Now I want to be really clear. Our access providers, and you can pull up the next slide, they are very well versed in communicating with individuals who have needs. So it's not just a telephone screening where individuals don't have the ability to provide clinical services and to support someone in need. Pull up the next bullet, please. So calls can be received from anyone, friends, family, individuals, providers, social services. It's important that anyone can contact our service line to have a conversation. We really encourage that. Next bullet, please. So the determination of appropriate services and the level of care services, that's really important. And that will be done based upon the telephone screening and information gathered. It's not just a one-time telephone screening. There are a lot of mechanisms by which we gather information, databases with historical information, contacting collaterals, and really a robust screening process. Next bullet, please. There are forms and tools. This is just a reminder that it's not it's a simple process for the beneficiary. They're not privy to all of the different pieces, but we consider this process to be really, really important, and we take it very seriously when we are looking at matching services to an individual needing care. Next bullet, please. And so just as a reminder, these forms use algorithms. So this is all evidence-based. There is a process by which we determine if someone meets mild to moderate or moderate to severe. You're looking at current symptoms, past symptoms, hospitalizations, any contacts with the criminal justice system. Senator Beal was talking about how can be so much contact with criminal justice, and really, is that an ideal treatment setting? We want to look at where individuals are touching our system so that we can best meet their needs. And then mobile crisis and any crisis services. Next slide, please. So I mentioned that you can move to the next slide, please. I mentioned that I work in the adult and older adult system of care, but I just want to briefly touch on our child and young adult system of care, and also share that although we have these separate systems, because in any agency and organization, you have to have an infrastructure that can be balanced, we work very collaboratively because, of course, this is a lifespan. We want to serve individuals across that wonderful lifespan. So the children and young adult system of care is part of Alameda County Behavioral Health that serves children and youth and young adults 0 through 24 years. So the 18 to 24 is a group that is called the transitional age youth. And they often require very specific services when they're in that age range. And this system provides mental health and substance use services to individuals, as I said, who meet full scope Medi-Cal and who meet our criteria. Please, next bullet. These are just graphics. You can go ahead and continue to pull those graphics up, just showing you the different ranges of ages and what those folks may look like and their smiling faces. Okay, next page, please. So this is one of our system maps, and there's a lot of information on here, and I'm not going to go through each piece, but I wanted to give every participant today an idea of what one of our systems looks like, just in this very great format, to show a division of services from, on our top left, county operated services to early childhood. I mentioned transitional age youth, juvenile justice, mental health. And then on our right, starting at the top, community partnerships, school-based services, which are so critical, adolescent substance use, and then our array of specialty services. Now, if you would like any more information about these services specifically in Alameda County, you can certainly reach out to me and I can connect you with our children and young adult systems operator. But the center of this slide just really shows you the contact information, which is similar to our adult system, but this just gives you the great overview of our youth services. Next slide, please. Now we'll dive in a little bit deeper to the adult and older adult services. Next bullet, please. So general mental health services, and I'll ask that these come up, they can just keep coming up on the slide continuously. So assessment, therapy, medication support, management, this can be case management, consultation, urgent medication support. So we have all of these services in the adult system. I mentioned case management. We have different levels of case management. So intensive, which is at minimum, individuals are connecting with their service provider at least once a week. Usually it's much, much more. And the whole philosophy is very much meet the individual where they are in the community. Next bullet, please. Inpatient hospitalization. So obviously that is our highest level, and some individuals may need an inpatient hospitalization either for a brief period or for a longer period of time. But our goal is to always provide a continuum of services so that those who are ready to discharge from inpatient can be connected to their case management provider. Housing services, I think we would all agree housing services are so critical. Also employment, outreach, and engagement. And the reason why this is so important, and I mentioned our transitional age youth population before, you'll find that individuals really require housing as part of their treatment. It's just so critical. And often, we certainly find with the intellectual and developmentally delayed population, employment is such a critical part of someone feeling very productive and part of our society. So we want to make sure that our services meet individuals in the community so that they can help provide them services in their housing. Community integration services for persons transitioning from criminal justice. Again, this is so critical. And there are some missing pieces here. Some of these systems are just so massive that there's an ongoing effort to break down these silos and make sure we work together with our criminal justice system. Next bullet, please. Prevention and early intervention. This is so key, and I emphasize the English limited proficiency services, but it's also important to note that we have a number of early intervention services across our system that are just so critical. Next bullet, please. Crisis intervention and crisis residential. I just mentioned this here. I will have a period further in our presentation where I will talk more about our crisis services specifically. And then lastly, forensic services. So I mentioned the linkage to criminal justice, but I just wanted to highlight some of our additional forensic services. We have a behavioral health court, reentry case management. This helps someone move out of that institutionalization in the criminal justice setting out into the community. We have our assisted outpatient and community conservatorship programs, which I will talk about next, and then felony diversion, which is just such an amazing program because diverting someone who has been indicted for a felony, who has mental health challenges, into the mental health system, away from the criminal justice system, is just so critical in our world, in our communities. Next slide, please. So again, this is just another snapshot of the services, and I divided it up by the crisis, acute, and inpatient. So these are the more high-level, immediate, episodic needs for individuals who are really struggling. We've had a number of our Schreiber Center clients who will have a period of instability and really need to tap into our crisis services. So those are really, really important. Medication and early intervention. I mentioned that earlier, and then highlighting our in-home outreach. ADROC is Adolescent Recovery Outreach and Coordination, and then adult, and then transitional age youth recovery outreach and coordination. Again, really making sure those systems are connected. And then familiar faces, those who touch our system a lot. We really want to find out what's missing. What services are we not providing for these individuals to keep them engaged? And then lastly, case management. We have clinics, we have wellness centers, we have community-based organization case management, and then we have our full service partnerships, which are our most intensive every day, meeting with our clients, making sure that they're doing well. And then lastly, AOT and CC, which I will talk about more in depth in the next slide. You can go ahead and pull up the two bullets. So we have, or all of the bullets, sorry. So assisted outpatient treatment, this is otherwise known as Laura's Law for some of you who may know it. This came about because of a tragedy where an individual lost their life due to someone who was experiencing severe mental health challenges. So our county adopted an assisted outpatient treatment program several years ago, and we currently have 30 slots for individuals receiving services. This is a great program because it's another innovative way to reach individuals who otherwise are reluctant to treatment. It uses the arm of the court, which is excellent and has the black robe effect. It's a civil matter, not criminal. Again, it's really important to move out of that criminal element. And it's statute driven, as I mentioned, Laura's Law. Not all individuals in assisted outpatient treatment receive a full service. I'm sorry, all clients in the assisted outpatient treatment program receive full service partnership levels of care, which is so critical. And we'll move on to the community conservatorship program. So I will just share that I worked on the development of the community conservatorship program. This again is another innovative program which allows individuals who, a prior speaker mentioned the LPS Act and the Mental Health Conservatorship Program. This program is a voluntary, meaning individuals can opt in to participate, but then they are under an involuntary conservatorship. However, it's full disclosure through the public defender that what they're receiving, what they're signing up for, is the same level of service that they would receive in an inpatient setting, but in the community. So you can imagine that that's incredibly appealing for individuals who would like to be out in the community. One particular CC client in our county did have a diagnosis of a developmental disability, and she was very successful in this program for a period of time, and that really involved a lot of interaction with all of her support services. So that is our community conservatorship program. And I know that there are a number of questions. I think those will be answered later. And I know I said a lot. I believe that that concludes my portion. If you want to move to the next slide. Okay, so the key takeaways from Alameda County Behavioral Health. If you leave with nothing else, please remember what we do is we provide services on a continuum for those who need specialty mental health. We have an array of services for individuals at different points in their lives. Remember that access to services, you contact us. We emphasize recovery, hope, and resiliency. We know that community-based providers are key. They are out there doing the important work along with our clinic staff. We are all about peer experience and lived experience. And we also have a very robust, culturally appropriate ethnic services division in our program. We're always looking at new innovative program designs. We use data, of course, it's so critical. We work to ensure a smooth transition, so from one piece of our system to the next. We've expanded the use of telehealth, haven't we all? We focus on program design to really meet the needs of all of our diverse community members. And I, as well as many other individuals in our agency, are always available to speak with you and talk with you about our services. And then the last slide is just our contact information. And later on in the program, you will receive my email. And I'm always available, and I can also put that information in the Q&A so that you can contact me at any time. So that concludes my portion. I know that was a lot of information. And next, I am going to introduce our Santa Clara County partners. We have Jennifer Pham, Michelle Ho, and Gabby Oliveras, who will present on Santa Clara services. Thank you so much.
Thank you, Vanessa. Appreciate that. So I'm going to start off first, and then I'll be sharing my time with my counterparts in the Adult and the Criminal Justice Division for County of Santa Clara Behavioral Health. Next slide, please. In terms of our county system, as was mentioned by Vanessa, the behavioral health system is a mental health plan, and we do support the specialty mental health services in the county. So our vision and mission is really to think about, the public behavioral health system. We want to be successful in being able to provide services that are physically and emotionally healthy, happy and thriving in a safe and permanent living, having clients in a safe and permanent living situation, part of a loving and supportive social network, involve clients that can be involved in meaningful school work activities and safe from harm from the environment or others. And our mission really is to assist individuals in our community affected by mental illness and serious emotional disturbances. To accomplish this, services have to be delivered in the least restrictive way, non-stigmatizing, most accessible environment within a coordinated system of community and self-care, respectful of the person's family and loved ones, language, culture, ethnicity, gender, and sexual identity. Being inclusive is really our focus, is to make sure our services are inclusive for everyone and anyone needing the support. Next slide, please. So for my division, I oversee our family and children's services. So the continuum of care that we provide is for birth through transitional age youth, which is the age of 25. And our services are really thinking about the developmental perspective and looking at how our services are built around the specialty of how development impacts our behaviors and our trajectory, and really thinking about services and building those services to keep that in mind. the services that are provided to our families is really based on what their needs are. So it could run from promotion all the way through intervention, and really just thinking about where the family's at and what kind of support do they need at that moment. Services also consider the ecological model and include all parties that may be impacted in a child's life and family's life, from their school environment, their teachers, community, social systems, such as maybe regional providers or other healthcare providers that are consistently in the individual's life. Next slide, please. So what you see here is our system of care, the children, youth, transitional age youth, and family system of care, and all the services that we have available under this umbrella. And looking at that, trajectory from prevention and early intervention services all the way through to residential care services. Specialty program supports are inclusive for all within these programs and available specific to, and some programs are available specific to supporting the DD/ID community. And we think all of our providers have training and understanding of the community, but we do have some carve-out programs that have identified, supporting this specialty population. One of those examples is our Kid Connections services, which supports our birth through 5 population. They're always taking into consideration the child's development and their behaviors. And the goal is to identify appropriate needs in support and linkage and addressing developmental and behavioral concerns. Our Kid Connection providers work closely with Early Start programs or San Andreas Regional Center and the school districts to make sure that the family and the child is receiving appropriate care, aligning services, making sure that the family understands what's best for them to support their child through their behavioral health concerns or any other concerns that they may be having. We also have our Therapeutic Behavioral Supports program that kind of spans this whole continuum, is available throughout this whole continuum of care. And we also have that special carve out for our TBSID, our Therapeutic Behavioral Services Intellectual Disability. And that program specifically is focused on providing adjunct supports that are added onto any other program that you see here on this continuum, and has that specialty knowledge of working with the IDDD community and providing those additional behavioral supports that can help the individual and the family develop skills and independent skills, and to be able to manage and support some of their behavioral concerns. So for me, in my oversight of our family and children's continuum of care, we are focused, and we are at all times thinking about what is best for the family and how are they being supported and what needs do they still have, and trying to get connections, linkages, support places, support services in place to really support that, and inclusive of all. So we do strive, and of course there are still gaps, but we know that there's always evolving and there's always need in the community to evolve. So at this point, I'm going to pass it on over to our adult division. Next slide, please.
Hello, good morning, everyone. Can you hear me? So hi, I'm Michelle. I'm the Division Director for our Adult and Older Adult Services Division. I'm in department. So I'm here to talk to you about the services that we have in the adult system of care, and particularly with the inpatient and residential services. So within our adult system of care, we have outpatient services, also known as the clinical wellness services. We have our criminal justice division, which my colleague will speak on later. I myself is in charge of the inpatient and residential services, both on the substance use treatment side and also on the mental health side. We also have the medication assistant treatment program that is also under our substance use division. So within our services, adult service system of care, the clinical wellness services is a division that provides the outpatient services for clients who are sponsored or unsponsored We have all types of levels of care within our outpatient services, ranging from case management to intensive FSP type of services. Our county also has the mental health urgent care that provides urgent care needs to clients and or consumers and their families. It is also a walk-in clinic. Our county recently just implemented same-day access within our outpatient urgent care clinic. And that's something that we realize that is very much needed in the community instead of having clients wait for services. So that's one of the things that we're working on to implement. We also have programs such as in-home support outreach, where clients, for those clients who are not connected to services, but will be provided case management services until they're fully connected to a regular outpatient team. Recently, within the past 3 years, our department has implemented different levels of intensive outpatient services that includes the IFP and also the assertive community treatment model. That is providing the highest level of outpatient services to our outpatient clients. I'll go ahead and skip the criminal justice services because my colleague Gabby will be speaking on that. In regards to our inpatient and residential services, we have a 24-hour care unit that processes our referrals, our residential referrals that come through our system. I myself oversees our EPS, and which is our emergency psychiatric services, and our inpatient psychiatric unit. We have staff that are placed in those sites to help with discharge planning, care coordination, case management, and placing the clients. Oftentimes we have a lot of regional center clients that are in our EPS. It is often very difficult to place someone that is from the regional center, mainly because there's a lack of placements that can accommodate this population. They're often acute when they arrive. Some are nonverbal, some are verbal, and a lot of them has to do with behavior issues. And oftentimes we get together as a team with the regional center and our colleagues within our department to help troubleshoot an issue. Although we say that our emergency service psychiatric service facility is supposed to be for 24 hours. Oftentimes when we have a regional center patient, they tend to stay a bit longer because of various reasons, no placements, too acute, or they're just not a provider that's able to handle the types of behaviors that they're exhibiting. We also have, sometimes we do send our regional center clients to a crisis stabilization unit or crisis residential if they're not that acute, and if our providers feel that they have a plan once they get there. Although, you know, it is sometimes very difficult for the nonverbal clients that have to that go into those facilities because they don't have the appropriate staffing to handle those types of needs. With that said, we never really, you know, turn anyone away or reject anyone when they come to our psychiatric emergency room. As difficult as it sounds, we always find a way to place them. If we can't find a placement for them while they're in our emergency room, what we do is admit them in our inpatient unit. Sometimes they stay for weeks, other times they stay for months, depending on the situation. We try our best to stabilize them as much as we can. So it's often challenging, but I think that the team collaboration is great, it's effective. We talk to Mike Keeley all the time and his team, and just our colleagues within our department, always getting together. We also have, besides our acute services, we also have contracted facilities such as boarding cares, IMDs, the state hospital, so that we can send our patients out once they're stabilized in our acute unit. We don't do it very often, but every now and then we do send a regional client to one of our boarding cares if they're not fully connected to the regional center, or if they need a brief stay in one of our boarding cares. The only place that it may be difficult for us to send a regional center client is to our locked IMDs. Those are long-term locked psychiatric facilities because of the amount of clients that are there. Each of those facilities can house up to 100 to 105 patients. So they don't have the one-to-one staffing that would be able to provide the kind of support that would be needed. Moving on to our substance use division, which I also oversee in terms of the residential piece of it. We have anywhere from services, anywhere from detox to residential to our THUs in our system. We also serve pregnant women with children who have a substance use issue. They also have some psychiatric services that mainly substance use treatment services. We also have intensive outpatient services, partial hospitalization as well. Within our substance use division, a majority of our services are contracted out to providers. The only program that is in-house is our outpatient clinic, our reentry center, and also our methadone clinic. We also have the medication assisted treatment program that is managed by my colleague, Mila. So that's, in a few words, that's pretty much what we offer. And next slide, please, or I think I'm not sure. I believe is that my slide? I'm sorry. Well, I can, Gabby, I think you're on mute.
Good morning. Did you want to do that slide or do you want me to cover it?
Oh, go ahead, Gabby. I figured.
Thank you.
Yours, yeah.
Thank you, Michelle. So just a quick overview of some of our adult special programs. We have a division, it's called the Cross Systems Initiative and Special Projects. And under that division, what we are launching is our assisted outpatient treatment. We will be going live with this program February of 22. So we're very excited about the possibility of, adding another tool to our toolkit to be able to serve populations that have difficulty connecting to our services. And a huge proportion of that population are people that are justice involved. We also have the development of residential and other behavioral health housing initiatives. As many of you know, treatment and housing go hand in hand. So we are looking at more innovative approaches to ensure that we have housing and treatment simultaneously. The other thing I just really want to comment on is the collaboration within our behavioral health partners and other partners, which is San Andreas Regional Center, HOPE, our collaborative courts, which I will talk about later, our public defender and DA. And lastly, we have supportive housing services. We have permanent supportive housing. All of our providers are trained to administer the VIATS-BDAT, which really gives a score to look at housing needs. And that's done very early in the process when people are, intaked and start their services. We have a full array under this division for mental health services that we provide. Also, connection to benefits. As many of you know, benefits, Medi-Cal, SSI are essential for our populations to be able to access other benefits, not just services, but things that will supplement income so that they can live, meaningful lives. Primary healthcare support, we partner with our Valley Medical Center, where we have clinicians that are stationed in primary care clinics that also provide behavioral health services, mental health and substance abuse. So we're really happy about all those efforts that we've been able to bring together through our collaboration. Next slide, please. So I'm the division director for justice involved populations. And what I do is I coordinate care with my team for people that are coming out of the jails and the state prisons. And the division is fairly new. In 2017, we decided that because people were being released from the jails, prisons without care connections, that it was important to formulate the division and ensure that we worked very closely with the state prisons and the jails to make sure that people weren't being discharged without a treatment plan. Part of our work entails working very closely with our collaborative courts. I have to say for the division, this is our biggest partnership. We work with Superior Court judges, we work with the public defender, the DA, and many of our behavioral health clinicians that are stationed in the court and our community-based organizations. So people come to us in a very non-traditional pathway. People get adjudicated through the process, they're arrested, they're booked, and then they appear through our collaborative courts where we provide a screening and an assessment. We go before the court and we say, we believe this individual would benefit from mental health, substance abuse treatment, because at the time of arrest, one, they were not taking their medications, they were not connected to treatment, or they were under the influence. And what we see in this court is that 98% of our consumers, for whatever reason, have not received the appropriate care that they need to be, to live meaningful lives and be successful in the community. 82% have co-occurring disorders, mental health, substance abuse, ASD, or some form of IDD that unfortunately was not caught or treated as children. So that's the way that you come in through our courts and you connect to services. Another way that people come through us is through our emergency psychiatric services. And usually this is after someone leaves the jail, they did not get that meaningful connection to treatment, they weren't part of this court, they end up in our emergency psychiatric unit. They're further evaluated and they're placed in our Barbara Aarons Inpatient Hospital. And also there is a referral mechanism, whether they're in EPS or Barbara Aarons, that they can connect to services. Another way that we receive our clients is direct referral from our probation, pretrial, and custody health partners. A lot of times we get contacted and one thing a probation officer will say, not sure what's going on with this person, they're acting rather odd. They are a little bit different. And so we're wondering if you could do an evaluation and let us know what we're missing and how we can best support this person to stay connected in community. And of course, to improve our recidivism rates. The other way is we have our Reentry Resource Center where people that release out of a jail or a prison can just walk in on site and they can have an assessment done. We also provide substance abuse treatment services there, so someone can be opened immediately. And all of our providers do have access to the jail. We can call upon our providers to go into the jail and start that engagement early on, especially for people that we see that haven't connected to services or did connect and for whatever reason did not stay connected. We've been noticed that they're back in the jail. We will call that provider and say, can you please start your engagement all over in the jail again? And all of our providers utilize evidence-based practice that are specific for people that are justice involved. Next slide, please. We do provide an array of services. What I want to briefly describe for you is our continuum of care. And again, these are evidence-based practice. It's proven that it works with this population. In terms of our community-based resource services, we have what's called our faith-based centers. This is not a traditional mental health or substance abuse provider. We contract with 4 churches to provide felt services. They provide flex funds, they provide housing vouchers. They are stationed at the jails because this is a non-traditional service. What we do at the jails 5 days a week in the evening, we provide information about our resources. When we've looked at pre and post tests, when people are coming out of the jail, a prison, they don't say, I want mental health services. They want to know when they're going to get their next meal. They want to know if there's support in the community. They want to know if there's a way to get back their kids. You know, what can they do to get a job? This is what our faith-based center does. And then moving on to our outpatient services, we have what's called our Evans Lane program. Very unique program because we provide outpatient and residential services simultaneously. We have all of our community-based organizations that we work with, Momentum, Gardner, Momentum, Gardner, they're escaping me right now, sorry. Momentum, Gardner, Community Solutions are three of our biggest provider networks that we work with. And also the providers that we work with at the Reentry Center. Then moving on to residential is our Evans Lane program, where people released from jails and prisons and they actually live there. It's a 56-bed facility. And also our providers can place clients there if they need a place to live. If we have an FSP provider, has a justice involved person that's just left the jail and they need a housing unit, they can live at Evans Lane. And then we have our intensive outpatient service, which we provide tight services that we fully wrap around someone when they leave the jail. We have a program that is 120 days. We have our full service partnership program. Someone can stay there up to a year. And then we have our forensic assertive community treatment team that is focused on working with people that are justice involved. And then moving on to our crisis response, we have a crisis stabilization unit. You can stay there for 23 hours and 59 minutes. And this is someone would go here right before going into, you know, a 5150 EPS situation, but maybe they need a moment to, you know, focus. They need to leave their treatment setting and just get placed here for a few hours to be able to integrate back into treatment. And then we have our crisis residential, which is a 21-day stay. This is the highest level of care that's in a non-lock setting, where we really kind of follow people very closely in these settings to help them, you know, are they taking their medications? We're providing them life skills, and we're integrating them to go on to work with an outpatient or another team. Then we have a very unique program, which is our STEP program. This is an in-reach into custody where we provide substance abuse treatment before people leave the jail. We provide groups, and then we help coordinate services once they leave the jail to make sure that that warm handoff happens. Did they get their medications? Are they able to connect once they leave the jail? And I do want to say that all of our criminal justice providers do that. They pick people up from the jail. They start the engagement while they're in the jail. Once somebody's leaving the jail, they help them get their medications and they take them to treatment. And they also coordinate their housing. You know, we really believe that it is important to make sure that people receive their medications, housing, and treatment simultaneously when people leave. We've really found that that is helpful as we're helping people integrate back into community. And of course, our acute psychiatric emergency inpatient services that I described earlier. So next slide, please. And then I just want to present to you all just some local resources that we have that support our clients. We have our behavioral health services, suicide and crisis hotline. It's 855-278-4204. We have our crisis support text line where you can text renew to 74741. We have our mobile crisis response teams that go out into the community all the time. The adult team, you can reach them through our regular 1-800 number, which is our call center, 1-800-704-0900. Then we have our mobile crisis response for children. The provider is Uplift. Their number is 408-379-9085. And then to access behavioral health services, which is the traditional way that we want people to access, is through our behavioral health call center, 1-800-704-0900. Our behavioral health services call center, the gateway that is for substance use treatment, and that is 1-800-488-9919. Our youth substance use treatment services The schedule is Monday through Friday, 9 to 6, 408-272-6518. And then our youth substance abuse treatment services after hours, which is 1-800-488-9919. Thank you so much for your time and opportunity to be able to discuss services for justice-involved populations. Thank you.
Lisa, we are happy
Hi.
to have you. Thank you for being here today. Great presentations by our behavioral health team in Regional Center. Lots of questions are coming in regarding how to get services. And one of the key things I think families can take away is how to distinguish between differential diagnosis. So everyone, I think you'll get a lot of benefit out of Lisa's presentation. Thank you, Lisa. I'll give it over to you now.
Hi, thanks, David. I'm happy to be here today. I'm Lisa Kleinbub, Executive Director at Regional Center of the East Bay, but a long career at Regional Center working as part of our clinical team. Next slide. I want to note, as we look at the population of people with IDD and mental health concerns, we really have to recognize that we're all complex humans with a range of perceptions, perspectives, gifts and talents, hopes and dreams, and profound disappointments. Everyone wants to maintain their dignity as they go through life. Next slide. Next slide. For individuals with IDD, remember that while this we'll talk about some of the generalities, each individual has their own life history, including both successes and challenges. With people with IDD, we'll talk about some of those general characteristics and also focus specifically on those with the diagnosis of ASD. Next slide. General characteristics that we might find in this population are concerns about social judgment and the ability to assess for risk. Many people can have some difficulties with self-management of behaviors and situations that they're in. We may see many communication differences, such as using communication devices and other alternative forms of communication. People may be more trustful than other people might be and more gullible. The opposite is also sometimes true, where people are more suspicious of people who might be in helper roles. People with IDD have a higher risk of physical and sexual abuse in their history. They also have a history, generally there's a higher risk of victimization, fraud, unintended criminal involvement, false confessions, a lot related to naivete in social situations, may attempt to please and go along with the flow, and just all easily taken advantage of. Next slide. Individuals with IDD have often struggled to develop and maintain equitable, reciprocal interpersonal relationships. Many people have not had the opportunity for social success or social learning because of how they've been educated and sheltered in very homogeneous environments throughout their lifetime. I hope that is changing, but it is about the history of many people that we all serve. Next slide. People may learn more slowly and need frequent repetition, review, and practice. There are many conditions that have some correlation with earlier onset of cognitive and memory decline than in the general population. We may be working at a more concrete level than with other clients, and people may have a shorter attention span and struggle to focus. Next slide. It's the rule rather than the exception for intellectual and developmental disabilities to occur with other conditions as well. And these can be neurodevelopmental disorders, medical conditions, physical conditions, and mental health conditions. Next slide. There can be also a vulnerability to stress, where people have not developed internal and external resources to cope effectively with stress. And small stressors, even tasks of daily living, may cause significant distress. And people, as I said before, may have limited experiences with success and accomplishments, so that some dependency may be part of their history, and relying on others rather than really being really strong self-advocates may be part of their history, and that may be something that needs to be worked on during any kind of treatment process. And some perceived lack of support may cause significant stress for individuals. Next slide. The other characteristic that is something I think many people associate just with autism spectrum disorder is also fairly common with other people with IDD as well. There may be perseveration on certain topics or questions. There may be some rigid thinking patterns and all or nothing or black and white thinking, and a struggle to generalize from what the current situation is and looking towards the whole picture. Next slide. Autism is a specific neurodevelopmental disorder that's characterized by difficulties with social relationships, reciprocity, specifically nonverbal communication, where people may really have a strong insistence on sameness and actually unusual responses to sensory input. This continues to be our fastest growing population in the regional center system, and is something that we are continuing to see growth in. Next slide. ASD, the common characteristics of the diagnosis are with social communication, so difficulty with relationships, limited reciprocity and empathy, and limited eye contact, gestures, or understanding of nonverbal cues. And also the restrictive and repetitive interest in behaviors, including speech, movement, insistence on sameness, rigid thinking routines, and that unusual reactivity to sensory input may impact how people engage in treatment options, and kind of the need to support a slow introduction of new ways of thinking and new routines into someone's life as one pursues mental health treatment. Next slide. Prevalence. And this is important because sometimes people say, in the past, we've heard a lot of people saying, well, people with IDD, people with autism spectrum disorder don't have other co-occurring mental health conditions. It's unusual. But that's not true. 70% of individuals with autism spectrum disorders meet the full criteria for co-occurring mental illness, and 40% meet the full criteria for 2 co-occurring mental health diagnoses. And individuals generally with IDD have rates of mental illness that are 3 or 4 times that of the general population. Next slide. Okay. What are the barriers to treatment for this population? Next slide. There's a tendency for diagnostic overshadowing. And really what that means is that people see the primary diagnosis and that overshadows other very real mental or physical conditions. People attribute anxiety to the ASD rather than seeing it as a valid mental health or other concern. People also see some expression of unease or anxiety or other sorts of different symptoms as being about the developmental disorder, but they don't see it as a separate condition. And actually, that happens a lot with physical conditions as well. People may be exhibiting screaming, crying, things like that. And people will say, well, that's because that's part of their typical behavior, and ignore a lot of very serious physical illnesses as well. So this is not just about mental conditions. It is kind of historic. And historically, individuals have not received adequate mental health treatment. And as I said, primary health treatment as well. Next slide. There's also, for this population, often a lot of difficulties with logistics, sites not being ADA accessible. Screenings and intake processes may not really be adapted to meet people's needs. People may not be able to physically fill out paperwork, may not be able to participate in a phone screening, may not use the correct language or terminology to describe their symptoms, and may not have insider knowledge of their symptoms. People may have to rely heavily on collateral information, and systems often don't encourage that kind of collaborative referral process. People want the individual to call by themselves rather than understanding that someone may need support in order to make a phone call and reach out for help. They also may need a longer assessment period, as it can take much more time to gather information from a variety of sources. And people always have a question about, do people meet the criteria for medical necessity? And I can go into that a little further in questions and answers. Next slide. So in assessing for mental health conditions with this population in general, that's not for everyone. So that's where one's clinical skills, getting to know the individual, are most important. Try to avoid using jargon or technical terms. Make sure that answers aren't being provided because those are the answers that people might think you want to hear. Oh, I'm fine, rather than really probing for what actually is going on. Probably important for many people to get permission and consent to obtain collateral information from other people, with children, parents, and teachers, with adults, with trusted support providers and others. Ask permission to get that information and to speak to others. Please follow the individual's lead and really attend to nonverbal behaviors. Next slide. And these are all diagnoses that are common in the population of people with IDD. Next slide. And I think one of the most important things when looking at the assessment is, are there changes from baseline behavior? So knowing how before people or the individual became worried about themselves and made the referral, what was the baseline behavior? What was the adaptive functioning? What behaviors have changed and maybe become more disruptive? Like with anyone, is sleeping change, is eating change, is elimination change? Are there changes in affect? And is someone having new internal stimuli? And it's really important to look at that baseline behavior, especially at a time like now during the pandemic, where so much has changed. People have been home and we're seeing people starting to go out. Is there a change now in how people are interested in approaching things since they've been sheltered for so long due to the pandemic? And how are the changes impacting the individual? Are they distressed by this? Next slide. Interventions in outpatient therapy with this population probably need to be supportive and collaborative in terms of problem solving, and collaborative in terms of working with the client, but also working with people who support them. Structured and concrete skill building. And there is evidence and research with individuals with ASD that cognitive behavioral therapy, dialectical behavioral therapy, and other behavioral therapies are very effective. Next slide. Always think about safety and make sure that some of the exploitation and bullying that can be common in this population isn't part of what's going on with peers. Assess for danger to self and others, any ideas of self-harm, and look at other avenues that are environmental factors and other kinds of support. Does the person have enough support in the current environment? Next slide. And then I think that these are things that any clinicians will be doing, but make sure that you are authentic and present with the client, that when you work with collaborative partners, that you still are putting the client first and not just talking to others around an individual, that you're looking at ways that you can engage. And things may require a longer time and may require more repetition, review, and practice in a number of environments. Next slide. And these are just some resources that we have, and I will make sure that in what we pass on as part of this, I send the links to these. They didn't come out very well in this PowerPoint. So thank you, and happy to take questions in the questions and answers or chat.
Whew, that's a lot of information over the last hour. I really appreciate all our presenters, and I appreciate our audience for taking good notes. I'm sure you have several pages, and I'm sure you're trying to figure out where all the arrows point in getting services. Couple of things before we move into our video and then our break. I want to give congrats to our first round of gift card winners. They were posted earlier on the chat, and you'll be receiving an email regarding that. We will be posting our next round of winners after the break. I hope you all are paying attention to our Q&A window. Just a robust conversation going in there. So far, 88 questions have been answered, 10 are open. Appreciate the questions. They're very insightful, and I am so happy that our panelists are offering answers. We will have question and answers toward the end of our presentation. This seems to be the best method to get a conversation going with such a time-limited symposium. It's hard to bring people up on our screens. And I just want to point out some of the things that Lisa was saying and that were kind of made evident when talking with regional centers and behavioral health. As advocates, there's a real need for you to, when talking about the needs for the person's developmental or behavioral health services, to distinguish the two, that this particular need is more developmental based on their IDD, and this particular need is more behavioral based on their emotional or mental health issues that they're being faced. By making that distinction, it'll help our clinicians and providers to recognize how to offer services within their particular system. Okay, we are going to take a break after the video being introduced by Brian Salata. The break will be about 7 minutes, and then we'll get back at that time, which would be about 11:25, I suppose, and we'll begin the conversation about what's going on in our care network by vendors and private contractors. Brian, share your video with us.
Okay, I believe that I put my video on. Can you all see? I'm not seeing it on my side.
Brian, you will not be sharing your video. Brian Salata will not be sharing his video. Brian Huang, our tech support, will put it up.
Okay, great.
No need to share. Go ahead, Brian, and introduce.
Okay, so hi everyone. We're glad you're here with us today. My name is Brian Salata. I am the program manager for Sunnyvale Children, Youth, and Family Services, and a liaison between Santa Clara County Behavioral Health Children and Youth and Family Services and San Andreas Regional Center, and also the proud father of two incredible young men, Trevor and Dylan. I want to introduce you to them through a video that highlights the journey that we have been on since our sons were diagnosed with autism at an early age. And while we have faced many challenges along the way, their mother, Elizabeth, and I have done our best to help guide and support our sons over the years to learn and to be an active part of the community. With the support of our regional center, our healthcare provider, our school district, our family and friends, our sons have graduated high school, worked at Amazon and other job programs, made friends, and learned a variety of living skills and activities. They're happy and hopeful about their future, and they have taught us much about courage, love, and life. I want to thank Alex Vo and Nam Lee of Hope Services for their sensitivity and creativity in making this video. And thanks to all the participants, tech assistants, and presenters for developing the symposium, and in particular, David Grady for his collaborative leadership. Finally, I want to express my appreciation to my friends and colleagues of Santa Clara County Behavioral Health and San Andreas Regional Center and our network providers for working together over the years to help our clients who have intellectual and developmental delays to reach their goals, engage their community, and improve their quality of life. And I'll just conclude by saying we can build bridges over the gaps together.
I think one of the things I notice as I'm getting older now is I look, and I always have looked at, what's the meaning of life? You know, what's the purpose? Why are we here? And one of the things that I've noticed is that this has been a helpful part of the journey in working with the boys, because it's taught me, I think, to take a look at life from a different perspective. My name is Brian Salata. I work as the program manager for Sunnyvale CYF, Children, Youth, Family Services, and I am the proud parent of two fine young gentlemen here. To my left is Dylan Salata. Say hi. Hi. And to my right is my oldest son, Trevor Salata. Say hola. Hola. Okay, I thought you'd like that part. When Trevor was born, I noticed that he had some differences. We took him to a neurologist, and he confirmed the diagnosis of autism. And shortly thereafter, that Dylan also has autism. But when they confirmed it, I think we went through all the stages of loss or grief that you initially go through. We were sad, we were worried, we were depressed. You know, I don't know. It's hard to say exactly, put it all into words, but it was a devastating event. Raising two boys who have special needs has really taught me a lot of things that help me with my work. Giving me information and understanding. I understand not only what it's like to be a parent, but a little bit more I get an idea of what it is to be in the boys' worlds. Right, Trevor? To know how important trains can be sometimes, and how important roller coasters can be sometimes, and how important it is to be able, you know, to have a dream of the future. So for Trevor, what's your most important dream?
I want to be an engineer.
You want to be an engineer. And then for Dylan is about his dream of moving to LA, and what else do you want?
A girlfriend who agrees to move with me there.
What's important about having a girlfriend for you, Dylan?
Give me company.
You want company?
So I can have a child too.
I really like to put myself in their position and see the world through their eyes. And in so doing, it's changed how I see the world through my eyes. I wanted to become even more involved working with special needs, to understand my boys and how to help them as best I could. I feel like it's helped me to empathize with what that's like. It sort of intensified that desire to be of help to people. So the one thing that I'm looking for people to get out of the symposium is the idea of collaboration and coordination. We each have a valuable contribution, and that's what we're doing, to see what each of us can do to be as helpful as we can in doing our parts together.
Wonderful. I'm going to extend our break a few more minutes. Let's go till 11:30. Thank you all very much. Welcome back, everyone, and congratulations to our second round of gift card winners. We will do one more offer of gift cards and then hold out the last portion for those who complete our satisfaction survey. We've gotten some great presentations from our speakers and an overview of how the system works, and now we're moving into the community care that's available for our community. I'd like to now turn this over to Abby Yin, the Director of Integrated Community Services, a unique program up in Marin County that is being very helpful in assisting with the navigation of behavioral health and developmental services for the community there. Abby, glad you're here. Thank you.
Thank you for having me. Good morning, everyone. I'm so happy to be part of this symposium. My name is Abby Yim, and I am the ED at Integrated Community Services. And we're a cross-disability services provider located in Marin. And we provide vendorized services with GGRC, Golden Gate Regional Center, and full service partnership contracts with behavioral health and recovery services with the County of Marin in delivering integrated living skills and employment services. And I'm here to share a brief overview from the service provider perspective on the advocacy role we have the opportunity to play in improving the ecosystem of care for people who experience co-occurring conditions. Namely, I'd like to highlight how advocacy with people we serve that experience co-occurring conditions in centering the system of care around their choices, their decisions, and the quality of collaborative care is essential in moving towards more integrated systems of care. So I really want to talk about how we can really put the focus on the people who experience the services. Additionally, I'll explain a visual in just a second as a way for us to conceptualize the life cycle of care for people who experience co-occurring conditions, as a way for us to really frame our understanding of how integrated services can operate. It's a really confusing system, and it's taken me quite a number of years to kind of understand it and wrap my arms around it. So I really want to help with clarifying what we mean when we talk about integrated services. And then we're going to be doing a deeper dive with some expert speakers who will speak about each one of the topics and share more about the work that they're doing to address this urgent work. So about 4 years ago, ICS entered into a consulting contract with Golden Gate Regional Center to do an environmental scan of the behavioral health services landscape in Marin. And in the course of that research, we found that the systems of care that are meant to overlap and coordinate care due to the co-occurring conditions of people with intellectual and developmental disabilities, and also mental or behavioral health conditions, were really siloed. And there was a lack of clarity at varying levels, from the really macro lens of understanding current regulation or policy of which system is legally meant to provide which services, to the more ground level service delivery of how people with intellectual or developmental disabilities are referred over to mental health providers. So this confusion was happening at varying altitudes, and it caused a lack of clarity. But the most concerning aspect was the tremendous amount of stress and increased crises that the lack of integrated care was causing the individuals we serve. So therefore, thanks to the funding of GGRC and their investment in partnering across systems, they really wanted us to extend our contract and to really think about how we could assemble a cross-system team to address this need. So we put together this committee called the All In for Equitable Care Committee, and it's made of a multi-level team of practitioners, social workers, and administrators. We have Sheridan from the State Council as a part of it, regional center administrators and directors. We also have leaders from behavioral health and recovery services with the County of Marin, to the Marin Community Clinic, and also Partnership Health Plan. But what's most important about this committee is that it's also made up of people who experience co-occurring conditions. So these are people who receive services from ICS and their families. So we continue to ensure that any changes or recommendations to systems change is really focused most importantly on improving the quality of services and the way that people who experience co-occurring conditions really experience their care. Their stories, their perspective on the improvement is really how we center our work. So within that committee, we assembled a separate work group to do a deep dive on ways each system could make internal changes to improving care while building collaborative system changes improvements. So if we could go to the next slide, I'll show you what I mean. So next slide, okay. So this is called the life cycle of care graphic. And we created this for a few reasons. Number one, we want to center all of our systems change improvements to be around the person, in this case, Maria, as we see here. So we wanted to represent her in the graphic. So we're always thinking about how do services or the constellation of care center back to Maria. The second thing that we wanted to do with this graphic is to attempt to clarify a very complex and nuanced work stream in order to organize and phase our work. So as we see, there's different phases here that we wanted to delineate the work. And in the graphic, we've really tried to systematically phase what we approach as a cross-disciplinary team. So our work group that I mentioned, that's a sub kind of part of the All In for Equitable Care Committee, this work group has really focused on the referral process. So we're in the final phases of a referral work group and have just had a meeting to discuss ways that we can approach our next phase, which would be crisis. Lastly, I'll say that as an advocacy agency that provides services, this process has been a real education. As all of us who've been attending the symposium can see, this is a very complex world to navigate, and it's a lot to understand and to really try to navigate. I'd like to encourage more providers to look for these opportunities to advocate for the necessary changes for integrated care. As providers, we are uniquely positioned to advocate with the people we serve, as we are oftentimes the people in their lives most fluent with their stories and can play key roles in holding systems accountable for improving quality, while always making sure that we're thinking about our collective responsibility to serve. I love the quote that people who are closest to the problem are also closest to the solution. I think that's very relevant here. If you have any other questions for me that you'd like to talk about the provider's role or how we've really focused the stories and the perspective of the people we serve, you can feel free to reach out to me. I'll put my email in the chat box. And then we can move on to the next portion.
Hello and good morning, everyone. My name is Cindy Florido, and I am the Director of the Crisis Response Project for the East Bay. Thank you for having me here to speak. Next slide, please. So this is what exists. We are a vendor of the Regional Center of the East Bay, as well as San Andreas Regional Center. CRP's first 24/7 mobile response crisis team started in '96 with the San Francisco Bay Area. Since 2012, we've grown to other regional centers in Northern and Southern California. We work specifically with individuals who are referred by their regional center case manager or service coordinator. We noted that over 85% of the clients who are provided to us, referred to us, do have co-occurring mental health diagnoses. Next slide, please. So what is working? The main goal of our team is to stabilize and assist with regional center individuals and families during crisis situations. We want to prevent unnecessary psychiatric hospitalizations and prevent police involvement. As much as we can decrease it, that's our main goal. We want to increase individual success in the community. Other services that are provided are training for caregivers and families. We develop caregiver abilities to manage future crises. We also provide follow-up visits and or calls after a crisis situation or incident. We provide welfare checks and short-term intensive one-on-one training programs, such as our crisis behavioral training program, as well as a forensic program that is specialized in working with regional center individuals who are in the court system. We provide behavior management for those individuals. The goal of that program is to reduce recidivism. Next slide. We also provide community outreach. I facilitate the crisis intervention training at the Oakland Police Department, which has Oakland police officers as well as surrounding county police officers, and that is done on a monthly basis. It's a partnership with law enforcement to improve individual safety for our clients, and it provides a foundation necessary to promote community and statewide solutions to assist regional center clients with co-occurring disorders. We also attend and are a part of the multidisciplinary forensic team, MDFT, which is a voluntary coalition of county law enforcement agencies, county behavioral health agencies, and allied service providers. The purpose of that is to assist those individuals with co-occurring disorders who are at high risk of involuntary hospitalizations or who are arrested for behaviors and or activities related to their disability. CRP is a part of this team to provide ongoing support to our regional center clients. These are some of the gaps or opportunities for growth that we see at CRP. Our program design is to provide de-escalation. We are a behavioral health first aid. Unfortunately, we do not provide treatment programs or offer residential placement or crisis stabilization homes. However, that is one of the questions that we get quite often when responding to a crisis situation. We want to improve the relationship and understanding with county mental health and court systems to better assist regional center and regional center individuals. And we also want to increase community trainings with ILS, independent living services, supported living services, as well as care homes to be accessible for them and the regional center individuals. We also want to increase contacts and trainings with our area hospitals. And lastly, continue to provide education for community providers with law enforcements, such as police dispatch, who are working with regional center individuals as well. Next slide, please. So that was very brief. And if anyone has any additional information that you need to be answered, please send a message in the chat, or you can contact us. We have the Regional Center of the East Bay, who we serve, as well as Regional Center in the San Andreas. And the formatting changed a little bit, but this is provided on the outline that we have for information for referral. So if y'all have any questions, please feel free to give us a call and we'll be able to provide you with assistance as much as possible. Thank you everyone for your time. I appreciate it.
Just quickly, I want to modify our schedule for the day. In the interest of time, we're going to have Vanessa Baker speak on the behalf of the behavioral health systems approach to crisis, and it'll be inclusive of similar programming services in Santa Clara County. And just to note that although we are focusing in on the Bay Area providers, that many of these services are very related throughout the state of California. You will definitely see different acronyms in terms of how these services are provided, but the general interest is pretty consistent throughout the state. The key as advocates is to learn the language of each community and utilize it for advocating for your sons and daughters and yourselves. Vanessa, you are up.
Thank you, David. Hello, everyone. Nice to see you all again. So I will launch into my very brief overview of our crisis services. Next slide, please. So I just have one slide, and I just want to reiterate part of the reason why it was so critical that there was a review of our county behavioral health systems is that these services are available for anyone who is duly diagnosed with IDD and a mental health issue, and that includes our crisis services. So although we have our specialty Schreiber Center Clinic that you'll hear about more later in the presentation, all of our other services can be accessed. So our crisis services have really been expanded over the last several years. And the reason for that is the identification of the need to, in many situations, have a softer approach, be available for someone in a very caring and supportive way when they're experiencing a crisis. So on our left, we have our crisis support services 24 hours a day. This is telephone support. This is for someone in a very real or perceived psychiatric crisis. So individuals, clinical staff who are licensed and well-trained at managing individuals who are experiencing a crisis are always available through the crisis support services program. And of course, they have been up and running throughout the entire pandemic, 24 hours a day at their center. We also have mobile crisis teams. They respond to calls from police, agencies, and community members to provide immediate crisis intervention. They have vehicles, they go out, they respond, they've got that clinical wherewithal to be able to respond in a non-intrusive and threatening way. And then of course, down on the bottom, we have our acute psychiatric hospitals, which our primary one is John George Psychiatric Hospital. And then we also have one on the Sutter Herrick campus. These are inpatient hospitals where individuals can receive emergency psychiatric services. Of course, they are more restrictive, they are inpatient, but of course they're absolutely necessary. And we work very closely with their clinical teams so that they can receive the support that is necessary. And on our right, we have our crisis stabilization units. I know some of our prior presenters mentioned crisis stabilization and crisis residential. Crisis stabilization, they are just absolutely wonderful facilities. I've been to these facilities myself here in Alameda County, and really the design is to be incredibly welcoming. They are positioned in communities and neighborhoods where individuals can easily access them through public transport or in the neighborhoods to give them that ability to be in a calm, supportive environment to help them stabilize at a very brief period. And often individuals in our crisis stabilization units will transition to a crisis residential program. So they'll have that seamless movement after that initial stay at the crisis stabilization, and then they can move on to receive medication management, et cetera, to further stabilize them. And then we have our mobile evaluation teams. So these are really wonderful. It's pairing a police officer with a clinician, which all of you are very aware of how critical it is that a clinician is available whenever there is police intervention for someone who has a mental health crisis. I know certainly we've had situations in our county, and I'm sure this has happened in others, where some of our clients will be so, there could be such a level of confusion and often a fear of the police, or even an attempt to engage police to kind of initiate, whether it be suicide by police. So it's so critical that a clinician be on site with the police. And this has been hugely beneficial in our county to allow individuals to receive the services that they need from that clinical standpoint. So this is a snapshot. And again, you can call crisis support and you can call our access line for any of the services through the other crisis programs that we have. And that is my very brief overview of crisis. Again, I shared my name in the chat or the Q&A, and my colleague Jennifer Yoon will also share that later. Please feel free to reach out with any additional questions. Thank you.
Thank you, Vanessa. I know it was brief, and I know this is a big issue for families. The key here is when connecting with county behavioral health, focus on the behavioral health needs that the child is going through. Primarily, you may reference that they have developmental needs, but remember, county behavioral support is to offer behavioral support services. So emphasize those needs. All right, once crisis is averted, there's a need for ongoing care and referral and more community-based treatment. And this is why I'm delighted to introduce our next two presenters, Sharon Cyrus Savory from California Start Services. I'll let you lead off.
Thanks, David, and thanks everybody for the opportunity to speak with you today and to share about California Start Supports and Services. For those of you who are not familiar with START, START stands for Systemic Therapeutic Assessment, Resources, and Treatment. And it's a community-based crisis prevention and intervention service model for individuals who are age 6 and older with intellectual disabilities, as well as co-occurring mental health needs. And while START is new to California, it has been around since 1988 around the country, and has been cited by as a national model in 2002 by our Surgeon General for mental health needs for people with IDD. So START's in 11 states. So we've been around for a while, supporting around 3,600 people around the country, 1,300 children or so, and around 2,200 adults. In the California region, both in the East Bay and San Andreas, we're supporting now around 200 people. Next slide, please. Next slide, please. So using Abby's life cycle of care, I'd like to walk through with you how START services are provided to the community in East Bay and in San Andreas at this time. So if Maria needed a referral, she would go through the Regional Center of East Bay or through San Andreas, and they would provide us with that referral for any child over 6 across the lifespan. And that person would have autism, perhaps, or ID and a co-occurring mental health diagnosis. And at that point of the referral, the START team would go out within 5 to 7 days and provide some intake, some assessment, meet with the families, and figure out how best to support Maria. Now, typically when people are being referred to us, they're in crisis. And so the START team would be collaborating with the case manager or the service coordinators to provide what we call a cross-systems crisis intervention and prevention plan. And that plan, the goal of that plan is to reduce crisis events, to prevent hospitalizations, police involvement. We do that in person. So we would be, when our phone rings, which is a 24-hour emergency support line that's provided to all families enrolled in START, or if the person's in a care home or in supportive living or independent living, we would respond in person to provide some crisis support at that time. In terms of treatment, the START team provides strength-based, solution-focused treatments that is culturally and linguistically appropriate. So we try to provide supports for people based on their own lived experience and based on their own personal needs. It is strength-based because we use positive psychology as our primary way of supporting people involved in START. And I'll talk a little bit more about that in a minute. Even though Maria may have come to us through crisis, through the regional center, and we're providing crisis support, we would provide some ongoing holistic care for Maria as well. So we would work with her team of providers in the community to provide trauma-informed, biopsychosocial approach. So we're not just looking at Maria's mental health, we're looking at any biomedical concerns and collaborating with her medical providers or psychiatric providers. We have a multidisciplinary team of people that work for us. So our medical director would be collaborating with all the people in the community who may be supporting Maria from a biomedical perspective. We'd be supporting the mental health providers as well. And we would certainly be looking at what sort of community engagement or community opportunities there might be there for Maria as well, that we can increase opportunities for PERMA. And I'll talk a little bit about PERMA later on. And we do this through collaboration with community providers. So we provide linkages with communities and we work together to provide some support for Maria. Next slide, please. So as you look at this slide, Maria comes to us at that red level. You look at the upside down triangle. So when she comes to us, typically she would be in some sort of a crisis situation. And as you look at our triangle, our goal would be to work with Maria over the next 12 to 18 months so that we can alleviate crisis and increase opportunities for Maria to thrive in the community. So we're looking, she's coming to us when she's really stressed, things are really happening at home or in the community or at school or in a care home. And we're looking at how do we help to beat the odds of Maria being hospitalized or engaged with the police department. And then we're looking for how can we support her to thrive in the community. If you look at our circle and the START guiding principles, that will certainly help you to understand. And a lot of what I'm talking about would need a lot more great detail, but we can talk about that at another time. So you see the START guiding principles: strength-based, positive psychology, building PERMA. PERMA means positive emotion, engagement, building strong relationships, providing opportunities for meaning for Maria, and areas of accomplishment. And working through our therapeutic coaches who work in the community with families particularly, but also care homes, to provide strategies and interventions about how to help Maria live a better quality life. It's wellness-based, again, so we're looking at not just mental health, but biomedical needs as well, nutritional needs as well, fun and engagement. What are Maria's strengths, interests, and skills? How can we connect her to things in the community that might help her to utilize those skills to thrive in the community as well? I talked a little bit already about the biopsychosocial aspect. We all know that quite a number of the people we support have had some traumatic experiences in their lifetime. Whether those traumas are big, what we call big T's or little T's. So the START team is very trauma informed, and we make sure we look at things and making sure that people who work with us are receiving the most appropriate trauma-informed care possible. We talked about cultural competence as well, working with families and individuals based on their cultural preferences, based on their linguistic preferences as well as making sure that for every person that we work with, we're providing person-centered, family-centered supports and services. So while the START model, there's fidelity to the model in what we provide, we also want to make sure that it is meeting the needs of every person that's referred to the START team. Next slide, please. I talked a little bit about this already, so next slide, please. So what's working so far with START? What have we learned since START's been around since 1988? We've learned that there's been improved psychiatric symptoms, which is the major aim of START, is to reduce the frequency and the intensity of behavioral health issues. We've had lots of surveys that have gone down around the country where there's improvement in caregiver experiences with the mental health systems, and we've gained a lot of insight about what caregivers need. And our goal and aim is to ensure that we're able to support caregivers. There's high rates of stabilization following crisis. So about 73% of the 3,000 crisis contacts that we've had in the year 2019 resulted in people staying home, not going off to crisis homes or psychiatric inpatient facilities as well. And we talked a little bit about reducing hospitalization and ED use as well. A major part of what we do that's worked very well for a lot of families is our in-home therapeutic coaching. We have a team of coaches both in San Andreas and in East Bay that works anywhere between 6 to 8 weeks, sometimes a little bit longer, in home with families, providing strategies, support, psychoeducation. These coaches are highly trained and they work collaboratively with the clinical team and community providers to support families. Next slide, please. So where are the gaps and our opportunities for growth? Right now, we're looking to increase linkages with community providers to provide trauma-informed care and other creative therapies. There just isn't enough people, and there's quite a bit of conversations in the chat around that. How do we find providers who can do that? So we're looking to increase that, increasing collaboration with hospitals and other community mental health services so they're aware of what START can do to support people they're supporting as well. Increased collaboration with schools. Right now, we're working with a number of schools to better support children who may be having behavioral health challenges in school, as well as to help with the transition. Transitions are often very challenging for the people we support. So we're working collaboratively with school to help with some of those transitions as well. We certainly want to increase our collaboration with mobile crisis teams and CRP and others, and increase collaboration with ILS and SLS providers. Right now, we do have a number of people who live independently that are receiving START support services. Next slide, please. And finally, a big part of what START does is to help with educating and increasing the capacity of the community to support people with autism, as well as people with ID and co-occurring mental health needs. And through the START community, the national START community, we have lots of opportunities for education and training. Each START team every month has a community education team, and it's an open forum. We invite the community to come and to collaborate with us as we look at de-identified case presentations, and we talk about how to best support people. So we're looking forward to people joining those monthly as well. There's 2 every month. We have the START National Online Training Series, which is conducted through our National START Partnership with the University of New Hampshire. And that's a wonderful opportunity for professionals to increase their knowledge about IDD and mental health, And that happens every third Friday, and the community is invited to participate in that as well. And we have the National START Institute, which happens annually. There's lots of research shared, lots of excellent trainings that's provided to the community, all in the goal of we can all work together as we increase our knowledge and increase all the information we need to support people in the community as well. Next slide, please. I think that's the final slide, actually. Thank you so much for allowing me to speak today, and looking forward to supporting more people in the East Bay and San Andreas community.
Hello, I'm Dr. Barron. I am here to talk about the Early Support Program for Autism, or ESPA for short. You can Google ESPA by putting in the terms ESPA and autism, and our website will pop up. ESPA is a joint program between Stanford and Children's Health Council, and it's free. ESPA offers 2 services. One of our primary services is for parents and caregivers of a child or youth who is newly diagnosed with autism. The other service we provide is working with parents, caregivers, professionals, and providers to answer questions about resources in the community for individuals with autism. We're really trying to fill a gap for the newly diagnosed parents and caregivers. ESPA provides 4 free sessions to support the parents and caregivers in either English or Spanish. Again, it's free, and it's in either English or Spanish, and we have no waiting list. Those 4 free sessions revolve around the diagnosis of autism, the various treatments that are available, the different resources that are available, and also ways to engage with individuals with autism. The second service that we provide is answering questions, again, from parents, caregivers, and providers about the various resources that are available, primarily in the Bay Area. Questions we get can include, where can I find a summer camp? Is there a speech links provider in my area? Who does pivotal response training? Again, you can go to the website, Google ESPA and autism together, and you will pop up our program called ESPA. Thank you so much for the opportunity to talk with you about our amazing free program.
Joan, thank you very much. ESPA is a tremendous service being provided in our area, something worth replicating. I am going to see, is Jennifer Yun on?
I am on.
Great. Jennifer, we're doing a little adjusting of our schedule to kind of meet our needs, and I'm wondering if you can talk about Schreiber. And I think your slides actually show up a little further down the list. Let me pull them up. So I'll let you go ahead, Jennifer, and then we will move it over to our providers giving updates on treatment. Jennifer, thank you.
Sure. So my name is Jennifer Yun. I am a licensed marriage and family therapist working at the Schreiber Center with Alameda County Behavioral Health. So I'm going to talk about the Schreiber Center. So what's existing? We're an outpatient specialty mental health clinic within Alameda County Behavioral Health, and we provide services to individuals with due diagnosis of IDD and mental health disorder. You know, it was created because of the awareness of the need to increase access and appropriate services for those that are dually diagnosed, and a desire to kind of bridge that gap Luckily, there was a great example within the Bay Area at the Puente Clinic in San Mateo, which I think you'll hear a little bit about later when Jean presents on the Puente Clinic. And they provided us with a lot of guidance and consultation in the creation of the Schreiber Center. And the Schreiber Center was named in honor of Mary Lou Schreiber and Robert Schreiber, who were two psychiatrists that provided psychiatric services to individuals in Alameda County who had dual diagnosis. We're a multidisciplinary team. There is a clinician, myself, and a psychiatrist, and we're overseen by our division director, Vanessa, who you heard speak earlier. And we work together as a team very closely on assessment, treatment, and consultations by looking at the whole person and the system. We get our referrals directly from the Regional Center of the East Bay or any Regional Center of the East Bay providers, and we're very fortunate to have this collaboration. It's very important to get some historical and collateral information, so we're glad to have that partnership. The services we provide are medication management through our psychiatrist, as well as psychotherapy services for clients that meet our eligibility criteria, and this is a Medi-Cal specialty mental health eligibility criteria. We serve adults 18 and up who are linked to the Regional Center of the East Bay. They must have Medi-Cal in Alameda County, a qualifying diagnosis that we do the assessment for, and significant impairments in their day-to-day functionings in one area of their life. Typically, these symptoms are moderate to severe, and our clients can participate in our services as long as they meet this criteria, as long as they meet the specialty mental health criteria. Next slide, please. So what we do is that together as a team, our staff evaluate and assess our referrals for appropriately matched care. The assessment is a very important part of our program, and if you don't meet criteria after our thorough assessment, we do provide referrals to either our mild to moderate network, higher level of care, primary care, or collaborate with our CEB case managers on what would be the best matched care for that client. During the assessment, we're able to meet with the individual and their team. So oftentimes the case manager will come with them, or any family, caregivers, anyone that the individual feels comfortable with. And that would be for the initial assessment. And we would follow up with them, do maybe one-on-one or smaller group meetings to complete the final assessment. We have flexibility to take up to 60 days to make the assessment. Sometimes we take a shorter amount of time so we can start services, and sometimes we take a longer amount of time depending on how complex the case is, or how long it takes us to get the information. And sometimes some people just take a little bit more time to warm up, so we want to be able to give that flexibility, and we're lucky to be able to do that. We collaborate with our behavioral health services. So we collaborate with our access line to support with referrals and help facilitate referrals to other services within our managed care plan, as well as collaborating with crisis services as needed. I think Vanessa mentioned earlier that sometimes our clients that are participating in the Schreiber Center may need some additional support at times. So we collaborate with different crisis supports within our system. We also advocate and work together with regional center case managers with the client's permission, of course, and as needed for other services that you need. Okay, next slide, please. So what's working? Increasing the ease of access to services for individuals that are dually diagnosed. Individuals, case managers, family are able to call the Schreiber Center, and do a phone screen, talk it through. We're our own front door. While you can access us through our access line, we also are open to getting referrals directly through our phone number and emails. What's also working is assessment and appropriately matched care. We're able to spend the time looking at the whole person and system. We have during the assessment, we're able to spend time one-on-one and as a group to identify the mental health symptoms that can sometimes get confused with and attributed to the disability. So we're able to take the time to really tease that out and make the differential diagnosis. And really treat the root of the problem and cause of the problem. So that's kind of what we're looking for in the assessment, is to make sure that we're providing and treating the correct problem and working on best match care. Another thing that's working is just our collaborative and integrated treatment. Because we're a multidisciplinary team with the clinician and psychiatrist, we're able to work together on the treatment plans, which has been very effective, especially supporting clients that may have emerging crisis issues, being able to just at ease talk to the doctor, or the doctor can talk to the clinician and work together on the treatment for that client. Also, our partnership with Alameda County Behavioral Health and the Regional Center has worked out very well, being able to collaborate with our managed care plan and other programs within our system, as well as collaborate with Regional Center and where the client can maybe access more services through their systems. And what's also working is the availability of therapy for clients who are dually diagnosed. There is a lot of concern around the availability of psychotherapy. Psychotherapy does work for our clients, and a lot of clinicians and service providers may find it challenging or may be intimidated to work with clients with developmental disabilities. So we're able to provide that specialized service. Next slide. So where can we do better? Where are the gaps here? We definitely always want to be able to provide more services for more clients. So, we want to be enhancing our services and continuing to partner with other programs. Engagement with managed care plans to ensure services for those that don't meet our criteria. So continuing to increase those partnerships with our mild to moderate network, perhaps with private insurance and groups. And some transportation improvements. Many of our clients are reliant on public transportation, other providers for their transportation services, family caregivers. So, working on transportation improvements to ease the access to get to our clinic or to get to other crisis supports. And of course, a theme I've heard throughout the presentation is more housing options, crisis residential, staff support, residential treatments, things like that. So, I'm hearing that there are, a lot of desire and passion to work on bridging those gaps, and we're happy to be a part of that. So thank you so much.
Great. Thank you so much, Jean. That was quick, but really Schreiber and Puente are just wonderful models of service delivery for people with intellectual and developmental disabilities through county behavioral health systems, worth looking at and worth considering creating in your own communities. Anna and Jean, they're going to talk about treatment. Thank you, Anna. Glad to have you here.
Thank you, David, and thank you for having me here. So my name is Anna Fernandez. I'm the director of the Behavioral Health Services with the HOPE team. So I would like to give you a little journey into our counseling center and the way we operate and the way we provide treatment. We are focused on the mental health part of the developmental disability, meaning we treat the co-occurring disorder. Next slide, please. So how we do that? We use a multidisciplinary team. I heard a lot during the symposium these terms. We have licensed and pre-licensed clinicians. We have psychiatrists on board. We have case managers, and we have behavioral coaches, and also registered nurses. And all of them will play a role in the treatment that I will describe in a moment. So I'm also heard a lot during the presentation today that sometimes it's hard to tease out what is part of the developmental disability and what is part of the mental illness, of the mental vulnerability. And I always say, you don't need to be depressed because you are developmentally delayed. You can have a good quality of life, and we can take care of your depression and help you to have a better life. Next slide, please. The model that we use is pretty much a systemic model that we use in our clinic, have into consideration 4 different domains. So first of all, when we do either assessment and treatment, because assessment and treatment really goes together and is an ongoing assessment and a feedback loop, and then we treat, we are looking first of all at the cognitive aspect, how our individual cognitively think, self-talk, believes. Because we are looking at this aspect, with therapy, we can operate at that level. And this is pretty much where team of therapists operates. Then we look at the physiological aspect. I heard a lot the importance of coordination with the primary physician, coordination with neurology. We have psychiatrists on board. They prescribe medication, are the ones that try to address the mental health problem through medication. But we also look at physiological aspects that can exacerbate symptoms, such as health problem, lack of sleep, diet, pain. So many times the pain that our individual feel has been underdiagnosed in my experience. Then we have a behavioral domain. Behavior is something that we can actually look at. A behavior is something that we can observe. We can see what is happening. We have, a lot of us deal with our client be aggressive, for instance. It's definitely something you can observe, even if you don't know the cause, right? So we have a team of behavioral coaches, especially for children. We have a TBS ID program, and they are trained in behavioral technique in order to address this particular situation with positive reinforcement and all technique that behavioral therapy can give to us. The last part that we are looking at is the environment. And when I think about environment, I think about our team of case managers. They are the ones that provide linkage to the community. They provide resources. They go to school. They try to activate resources in the community. And in the environmental domain, we are really looking at the physical settings, the home, school, play, extra activities. And I heard a lot talking about individuals with autism, how important it is to have an environment that is stimuli-free in a way to better interact and have a therapeutic intervention that is more meaningful. Next, please. So at the Hope Clinic, we have several levels of operation. Intensive, that means we put in this department adult and children with higher need. We are an outpatient clinic, so people come or we go to the home or we are a community-based organization, so we work in the community, but we provide intensive, means more hours of services if the assessment requires it. Or when we stabilize our clients, we are going to normal outpatient, and it's pretty much same kind of intervention, but at a lower number of hours. TBS ID, we provide the services to children 6 to 21 that are at risk of psychiatric hospitalization and to prevent a psychiatric hospitalization or to prevent a higher level of care. We also partner with the regional centers because they are helping us in some situation when we cannot go through Santa Clara mental health, and they help us to provide mental health services when the client is not eligible. There are some medical necessity issues, and they are, as they said, the provider of last resort. Next, please. So what we use to help our client, we use evidence-based practices, Trauma-informed theory is very, very important. We are talking about our population really be a risk of trauma, victimization. We see a lot of post-traumatic stress disorder, but all our theory are our approach are trauma-informed. We use CBT, cognitive behavioral therapy, and the variation of DBT. We use systemic theory. We also operate at the system level, and we operate at the family level. And we are also welcoming in our clinic other evidence-based practices that our therapists are trained on. I can just mention play therapy, for instance, narrative, or also art therapy. We have a couple of clinicians certified in art therapy. But one point that I want to make when we talk about evidence-based practices is always important to really be client-centered. Because regarding the different disability and the level of functioning, all these theories need to be bridged in order to meet our client where they are. And we train a lot our staff on understanding the different level of functioning in order to be really able to provide effective therapy. Next, please. So another piece that I want to share with the group is that it's very important using data to figure out if our treatment is successful or not. And we have goals, we have agency goals. We want to be sure that we are there to reduce the suffering from mental illness, having more meaningful activities in school. We want to be sure that if there is a substance use problem, they can access treatment and relationship. I heard a lot this isolation in our population. So how to enhance relationship, what we are doing in this arena, and of course, reducing incarceration. So if you can go to the next slides, I want to show you how at the counseling center, we measure these goals. Can I see the next slide, please? Thank you. So every 6 months, we do survey. We survey both clients and significant other, because for our population, the caregiver, the significant other really play a role that is very important. And we want to see if our clients are improving, stable, or not improving. So we, as you see, we always have this feedback loop to figure out what the agency is doing and if we are on the right track. And if we're not, we really want to improve our treatment and be more effective. Next, please. So, bridging the gap, I can tell you that in our experience, as when we treat our population, sometimes we have some challenging in find a residential treatment that can do both the behavioral health piece and the disability piece. Intervention, we always ask ourselves which is the best intervention we can do, and research are becoming much more fertile in this kind of situation. Maintenance of our population in the environment that is less restrictive, and definitely access. We know that a lot of families have problem in accessing our services, and it's an ongoing conversation that we like to have. Next. So we understand that it's important that we are there for our client, that there is room for improvement, and that there is always an ongoing conversation with behavioral health, with Santa Clara partner, that I thank so much for many years of good partnership, and with the regional centers that I also thank for years of very fertile relationship. Thank you so much for having me today.
Wonderful, Anna, great, thank you so much. We are heading toward the end of our symposium. We're doing our best to stay on time, but we do want to have Jean McMaster be our final presenter today. Jean is going to share with us some of her CBT techniques that she uses over there at Puente Clinic in San Mateo area, CBT, Cognitive Behavioral Therapy. Jean, go for it.
Okay, next slide, please. Next slide. And next slide. Thank you. Let's see. I think this is actually pretty obvious, so I'm not going to go over this. So let's go on to the next slide. And before I do this, I do want to let you know that my name is Jean McMaster, and I am the psychotherapist and intake coordinator for the Puente Clinic in San Mateo County with behavioral health and recovery services. We're an outpatient clinic. We provide psychotherapy. There's one psychotherapist, and that's me. And we have 2 psychiatrists and 1 psychiatric nurse practitioner to provide the medication assistance. So, and 13 years ago, Puente Clinic did not exist. It came about because of some very dedicated and imaginative leaders at BHRS, especially Dr. Celia Moreno. I wanted to mention her because she had her radar up, and when the developmental centers were closing, the Mental Health Services Act came about. So there was funding for a specialty program like ours. Before we came along at San Mateo County Health, they didn't really have any kind of specialty program to help people with both intellectual disabilities and mental health issues. So, I wanted to mention that, especially because I know we also want to talk about bridging the gap next steps. So it's important for people who are in the area of finding funding to be alert to these kinds of opportunities. Okay, so on to the, so for Puente Clinic, especially when we started, the eligibility, because we're so small, is that you had to be returning to the community from a developmental center like Agnews or Porterville or something like that, or they'd be recently returned to the community from a locked facility. And they're at risk for a higher level of care. So currently, our doctors' caseload is so saturated that they had to up the criteria to for medication help for people who don't have any verbal skills, so they're nonverbal. Obviously, in psychotherapy, I do see the people who are verbal. Okay, next slide, please. So some of the other presenters talked about some of the therapy issues like transitioning to community living, adapting to independence and danger, age-related needs, aging parents, bereavement, loss of physical and sensory abilities. I'm coming across that a lot in the last year. Abusive histories. Some rather older statistics show that about 80% or more of our clients have abusive histories. And that continues. Trauma, there's shame and stigmatization. So I work with them in managing their feelings about hearing voices, anxiety, anger, jealousy, housemate issues, and enmeshment, and negotiating romantic relationships. Next slide, please. So some folks talked about the diagnostic quandaries before. So over pathologizing, the behavior they're evidencing may be appropriate given the level of development. So we always need to think about where is the client developmentally. I've had some clients who seem to be about like at 2 years old when they're 24 or 62. So it's really important to approach them knowing, have a sense of where they are developmentally. So there's often a very thick chart, including multiple diagnoses, some of which are inaccurate. So we need to sort those out. Psychotic diagnoses are frequently overdiagnosed. Someone else talked earlier about diagnostic overshadowing, where you mistakenly underdiagnose, attributing the symptoms to the developmental disability. And oftentimes we'll get a referral and someone will say, well, the client is showing aggression. It's like, well, tell me more. How are they showing their aggression? So then we can, approach it from what's really happening. Next slide, please. So you have to think about, who's making the referral? Do they have some kind of underlying issue? Have there been recent changes, new setting, a new resident, a new program? We have to think about physical illnesses, like is it menstrual, gastrointestinal, hearing issues, sinus. Are they in a pathogenic environment? In other words, are their behaviors supported by their environment? And never assume that all basic needs are being met. So like I've had some clients who have experienced severe poverty in their youth. And so they might turn to hoarding. So that can turn to hoarding behaviors. Next slide, please. Okay, so these are the different disorders that we approach. So I think you can see on the slide, depression, mania, those kinds of things. Let's go on to the next slide. Anxiety disorders, panic, intermittent explosive disorder, which could be panic. You might see a gag reflex. People being hypervigilant versus learned behavior. So we need to sort that out. So let's go on, because I know that David wants me to approach the way that I work. So next slide, please. So there's often issues about psychosis, and you can see here some of the issues that come up. So next slide. Factors unique to therapy patients with intellectual disabilities. They're typically not self-referred. So, they might really want to be there, they might not. So you need to assess that out. There's the involvement of many other people in their lives. There's more fear of criticism resulting in pleasing behavior. So you want to be careful about that. They tend to be more passive and dependent. They have less experience with safe, confidential relationships. So it's really important to use a lot of empathy and establish trust with the clients. They have a lot of difficulty. Well, there's communication challenges, difficulty reporting on internal states. So that's something that you need to just really aware of, and helping them and learn how to verbalize that. And they have very limited power to change their life structures. Next slide, please. So what you need to do is you formulate a goal based on the client's needs. You want to include others, like staff at the home, but you want to keep clear boundaries as to therapeutic boundaries, because some people can come into a room and try to take over. So you have to really establish those boundaries. You want to teach about and maintain safe, confidential relationship, because most of our clients aren't used to that. They go to a meeting at GGRC and there's a whole table full of people listening to all aspects of their personal life. That's really rough. We want to encourage self-advocacy and independence as much as possible, and help the client identify what they can change in their lives to improve their situation, and really support them in doing that. Next slide, please. So you need structure and consistency. This is where CBT comes in. Cognitive behavioral therapy is very, very useful with this population, but in my own personal approach is deeply steeped in empathy. So you want to focus on the concrete versus the abstract. It needs to be goal-directed. You want to have a lot of modeling and practice. Patience, lots and lots of patience. You want to involve caregivers, invite them to sessions, perhaps send some notes to the home. And I frequently talk to staff at the home. Okay, next slide. Okay, so relaxation training is a huge part of my practice. I teach breathing exercises, deep breathing, belly breathing, sometimes using a pillow. There's an exercise that Chad Lejeune taught me. He was the one who trained me about breathing, where you sniff the flower and then blow out the candle. So it's a good way to help these clients relax. I have used excuse me, a worry box for clients, especially if they have generalized anxiety disorder. So it's kind of a fun thing for them to do if they have a little box and they're really worrying about something at night, they can't go to sleep. So have them write down something in a piece of paper, put it in the worry box, and then say, okay, the worry box has it, you're okay. Okay. Magic cards. I use, let's see, muscle relaxation. So I do muscle relaxation exercises with them, a lot of stretching type of exercises. And you can see the different ones that I use. I also use mindfulness training. So like a color game, if they really need to focus, then I'll have them like choose a color, what's your favorite color, and point out to me, what do you see in the room that has that color? And it's fun. So, and hand lotion, which is just another way of helping people relax. Okay, next slide, please. So you want to use all your available resources, the family, the home staff, excuse me, the day program staff, the GGR social workers, which in my mind are just amazingly helpful. We work very closely with the GGRC social workers. Adult resource management has been incredibly helpful. Betty, thank you. And CBEM, which I always have to look up what that stands for. It stands for Creating Behavioral and Educational Momentum. And it's a team that we work with very closely, and they really help a lot, especially with behavioral issues. That's their specialty, is the ABA. Okay, any more slides? Helpful attitudes. Okay, do not underestimate the client's ability to benefit from therapy. The power of empathy, the value of creativity. You got to be flexible. You got to be creative. The importance of respecting the individuality and dignity of every client. And the value of keeping a sense of humor, because a lot of funny things happen, and our clients love to laugh with you. So I think it's important to keep that. Thank you. I think that's the end of my slides.
That's wonderful. Jean, we were so happy to have Jean be a part of our planning team. The message here is clinicians, particularly those who are in training, MFTs who are still in school. The answer is yes, people with developmental disabilities do benefit from clinical care, and the goal is to create good strategies to offer treatment. Okay, we are a bit over time. Next step is to have Tara Beckman introduce the video of our next video. Go ahead, Tara.
Thank you, David. Good afternoon, everyone. Again, my name is Tara Beckman, LCSW and Chief Program Officer at Hope Services. I am pleased to introduce a video featuring Eric Lee, Clinical Manager at Hope Services, and Plamen, one of our clients. As you will see, this video highlights Hope's care philosophy and the importance of establishing a strong therapeutic relationship with our clients. In 1913, Sigmund Freud hypothesized that the relationship between the therapist and the patient was a key component of successful treatment. Since that time, research has shown that the quality of this relationship, the therapeutic alliance as it is called, is the strongest predictor of whether or not therapy is successful. 3 essential qualities: an emotional bond of trust, caring, and respect, agreement on the goals of therapy, and collaboration on the work or tasks of the treatment is crucial to treatment success. The therapist's ability to communicate empathy, understanding, openness, and flexibility to the patient is also very important. Skilled therapists actively solicit patients' input about the goals and methods of treatment in order to facilitate collaboration. As this video demonstrates, Eric did an exceptional job of creating a safe, open, and non-judgmental environment for his client. Our providers' expertise and specialized training is a key factor in helping our clients to reach their desired goals. But equally as important is the dedication, care, support, and kindness demonstrated by our providers at Hope Services. I hope you enjoy this video.
When Plamen started counseling with us, he was pretty sad. Both of his parents had died, and he also had a lot of obsessive compulsive behaviors. He was scratching a lot, like there were open wounds all over his arms, face. He had a lot of ritualized behaviors, a lot of staring behaviors. I mean, like he's a 6'2" guy who stares at you at a supermarket, like it would be a little bit intimidating. Plamen, do you want to hurt people?
I don't like hurting people.
No, like what do you want to do to people? You want to
be nice.
You want to be nice, and like I generally think that like most people want to be nice. The most important part of any therapeutic relationship isn't the theory I use or the interventions I'm using. It really is the therapeutic bond that we have. And so with Plum, a lot of it was just getting to know him and like viewing him as somebody I want to get to know. And then once I had that good relationship, then we could start working on things like me pointing out when things were happening because he wasn't aware of the behavior. So do you remember when I used to be like, Plum, and you're scratching? Yeah, and that used to happen a lot, right?
Right.
Yeah, and then it was, once we got through the awareness of it, then it was the, okay, let's find a replacement behavior. Like the scratching that he had was not an intellectual disability. It was a real sign of a mental health need. We worked on some social behaviors about, like, how long are you allowed to stare at people?
1 second.
1 second, and after 1 second?
I go back.
I go back, yeah. And then eventually, once the behaviors were done, then I wanted to address the root causes, which were the grief and loss around his parents. And so we talked first about Mom, and then about Dad.
Right, but I really miss my mom.
I know. And you miss your dad too?
I miss my dad too.
Is it still a little sad?
A little bit sad.
Yeah, that makes sense. It's always going to be a little bit sad. I want to work where the need is greatest. And to me, this is where the need is greatest because as a gay man, like, I know what discrimination feels like. And it must be incredibly difficult if there's this layer of judgment on you. It's really hard to get away with discriminating against a gay person nowadays, or a Black person, or a woman. It's a lot easier to silently discriminate against somebody with needs. And so when I work with my clients, like, I remember like the humanity that they have.
That was really inspirational. Just a real treat to see those videos. Thanks to all. We are going to adjust our schedule. I know we are to have an end of our meeting at 1, and I know many of us have busy schedules and need to move on. When planning for this symposium, we knew we'd have a lot of participants, and we've had about nearly 300 all day today, which is great. And we knew we'd get a lot of questions, and we've managed the webinar so that I believe our audience has been able to get a good overview of our behavioral health needs. We're doing our best to manage the questions, and I think our QA feature has been effective. We have had over 125 answers. We are going to go ahead and move to our call to action, and then we're going to allow those who need to leave the symposium at 1 o'clock to do so. But we will have a few panelists remain for a few minutes after 1 o'clock to answer those questions for the floor. I and perhaps a couple of other symposium coordinators will ask those questions. So we will plan to go a little longer, but that will be for questions and answers only. So I hope that makes sense. I wish we had a little bit more time. This would have been something we could have done, I think, if we weren't doing it by webinar and in person, but we're faced with these time constraints. With that said, I am delighted to introduce the Director for County of San Mateo Behavioral Health, Mr. Scott Gilman. He is been working in San Mateo County, I think for a brief time, maybe a year or more, but he comes from from Michigan.
Correct.
States have responded to this need, and he's going to give us our call to action. Scott, we're delighted to have you here. Thank you so much.
Thank you, David. Yeah, I've been here for almost 2 years now, and came here after a 30+ year history of working in behavioral health in Michigan. And one of the nice things about coming to California is I've noticed in some areas California is light years ahead of the rest of the country, and in other areas, unfortunately, California is light years behind the rest of the country. I think that everything that I heard here today, I just want to say kudos and thank you to everyone that put this together, and thank you for your time. I was especially energized by Senator Beal this morning when he talked about a behavioral health system. As I look at the programs and the services that you've all put together here, it's really heartwarming and it reminds me of my days of working in Michigan, where there was one system. It was a fully integrated system with mental health, substance use, and IDD services all under one umbrella. And really in the communities that I work with, all responsible under one system. Now, it didn't take a couple of meetings to get that done. It was really decades that it took to get there. And it was a very difficult process, for some to get through. But keeping the vision at the end of what you're all trying to accomplish really, I think, is critical. Now, I also think, as I'm giving kudos to all of you for all of the great work that you're doing, I think it's also important that you keep the Grinch away. And what I mean by that is California is making a major investment in our systems right now for IDD and for mentally ill folks. Call to action number one is make contact with your elected official at the state level, no matter who that is, your senator, your assemblyman, and just tell them thank you. If you're not sure who they are, reach out to your state association that you belong to, find out who they are and start to form that relationship. If you're going to make the sorts of changes that we need in California to really move our system forward so that we don't have a gap, we don't have a huge gap for some individuals, we really need to start advocacy efforts, and it has to start at the top. And so it's critical that the three legs to the stool are working together. First is strong advocacy efforts through your state associations. Your role in that is to make sure you connect yourself to the association that represents you, your views, how you want the system to go. The other role that you have, the other call to action is we need to form alliances, close alliances with elected officials at the state level, those that really will be our champions. And I know some of you have dealt with some of them already, but that's important. That's the second leg of the stool. The moms, dads, providers, you provide the votes to get the attention of the elected officials, and you also provide the machine behind the state advocacy. And then the third leg to that stool is working closely with state administrative staff. I think we have a state administration that's dedicated to this, but wow, is it a confusing system, especially for a newbie coming in and trying to figure this out, looking at how easy it is, for example, for people to get left outside or to fall through the cracks. It shouldn't be so easy for that to happen. And there should be accountability when that does happen. And we need to build that in, and we need to work collaboratively with our electeds, our administrative staff, and our advocates to make sure that we do that in a thoughtful way so that your loved one or your consumer that you're treating doesn't fall through the cracks. So the other thing that I want to mention is that when we start to go down this road of integrated services, and having lived through this in Michigan with the integration of substance use and mental health, same dynamics come. We get a lot further ahead as new resources come into the system if you talk about using new resources to build what you want. Michigan, we had about a 10-year battle over the integration of the two systems, just because one system thought the other was going to take their money. So if you lead off, if you lead your discussion, if you lead your advocacy with there's money over there, people are just going to lock their doors, and it doesn't lend the kind of collaboration that we heard about during today's workshop. I also want to state that the workforce is dwindling all over the country. California, that's not unique here. In Michigan, we had such a severe shortage that we lobbied and actually had a direct wage allocation that went directly to workers for $2 an hour. So the competition is steep. When people can go to a fast food restaurant and make more or have better benefits than they can working with our population, something's wrong. And so as new resources come into our system, work with your advocacy organizations to make sure that the dollars actually get down to where they're supposed to go. Not only the direct care staff, but also the providers that you heard. There's some incredible providers here today doing great work, and the new funding should be reflected in their rates. We need to make sure that the money gets to where it's supposed to be. And finally, I just want to tell you that, and Senator this morning also mentioned this about telling your story to create a sense of urgency. If and I may be wrong, I haven't been here that long, but as I see some of these gaps in services across the state, for example, both mentally ill folks and folks with developmental disabilities getting stuck in emergency rooms, getting stuck in hospitals, it just seems to be accepted that that's a problem that we have to fix, but I'm not seeing the urgency. And I'll tell you, if my kid was stuck in an emergency room because they needed heart surgery, there would be a sense of urgency there. And so tell your story when these things happen all over the state. Work with your elected officials and again with your advocacy groups, and make sure that there's a sense of urgency to moving our system forward and to doing the sorts of reforms that we need to do to support you. Abby's story about Maria, that was just, again, another one that warmed my heart. But it shows how convoluted some of our systems are and how much work has to go into coordinating all of this stuff. Wouldn't it be great in a future vision if a system came in and provided all of those services almost as a one shop and really supported her? So congratulations, Abby, for what you've done. I think that's great work. And finally, you know, as you're telling your story, one of the stories that I tell when I first started working almost 13 years ago with the developmentally disabled population in Michigan, I had a mom, and you all know this mom. She's fought her whole life for her son, trying to keep him out of, you know, state institutions, trying to get the resources that he needed, and just fiery, you know, at every one of my board meetings. And finally one day, after she had lit up my board and lit everybody up about what we weren't doing, I sat down with her and asked her, you know, I actually went to her living room and said, you know, what do you want? What can I do to help you? And it just took my breath away. She looked at me straight in the eye and she said, I want to be able to die. And I can't die right now because this system that you have in place will not support my son. It will not take care of him. I don't know what's going to happen to him, and I want to die. I'm old. I want to die. And so, for me, that was my call to action, to learn a lot of how the world goes round and how to do the sorts of state reforms that are necessary to really make sure that when parents get to the twilight years, that they can be assured that we collectively will come together and make sure that our system is so tight and so integrated that parents can move on without really worrying about what's going to happen to their loved one after they're gone. And so, David, I really want to thank you for allowing me, you know, to make a few comments at the end. I'm also very willing to take, you know, people want to contact me after. My contact information is in the chat. Very willing to reach out, or if anybody wants to reach out, very willing to take any questions at any time. So, so thank you.
Scott, thank you very much. All right, 12:52. It just seems like we got started. Oh my goodness, what a day. Just big thanks to our presenters, our tech support team. If we can move to the next slide, I just want to remind everybody, our sponsors, we really have an amazing group of experts to help with this. So we are going to I'm going to do a final statement and then keep the window open for a little longer. And for those who have questions, we will be asking them out of the Q&A window, allowing the panelists who remain to answer them. And probably be on for about another 15 minutes beyond the 1 o'clock time frame. And again, apologies. I have this thought that before you can, you know, that old riddle about how do you eat an elephant, and the answer is a bite at a time. What you first need to do is acknowledge that the elephant is in the living room. And that is really pretty much the aim of today's symposium, is to share with you how we in the service system understand this elephant in the living room. Now begins the task of dining. It's clear that this is not an endpoint. the aim is to begin the task of moving forward to address the need for improved integrated services and capacity building. I'm sure many of us wish we had more time to discuss this important need. There is time. State Council has no intention of stopping here. Now begins the hard work of change. As noted earlier today, we will be sending everyone a link to our satisfaction survey. And in the survey, there is a request for interested parties in wanting to work with us to begin developing strategies to integrate improved care. Please add your name to the list and we can contact you and we will move forward in bridging the gap. So we do plan to organize into small groups, committees, and better identify this need and better identify strategies to affect policy. So thank you once again. If we can turn off the PowerPoint, open the floor up for our panelists. I think we'll be able to ask a few questions going till about 1:15. And while we're getting the panelists to show their screens, again, we had a robust conversation in the Q&A. We're gonna copy and paste those questions into a form. We will also attend to some of those questions that did not get answered. And we will entertain ideas about how to maybe create forums where we can perhaps ask our provider networks on how to get, where we can ask questions. So I thank you for your patience. I know Q&A is always important, so but we did have to modify it for today. Okay. All right. Is this our panel? I think so. All right. I'm going to just start off. We have and I'm going to ask our panel to give 1 or 2 minutes per answer. My first question, because we have so many that we need to answer, from each of your unique perspectives to better assure people with intellectual and developmental disabilities receive coordinated behavioral health services, what do you believe is the most important area that needs attention and or reform? And how about we have Uday as a board member at NAMI start, and then we'll just kind of pass it on to the next person. You all get about 1 or 2 minutes to answer.
So I think the issue of coordinated care, that's a big challenge. I think there are 2 systems, 2 siloed systems, and I think that's a real challenge. The Department of Development Services and then the Department of Social Services, you know, they kind of set the tone. And you know, there was an article published by National Association of State Mental Health Program Directors in October 2004 that said that people that face barriers to services related to lack of coordination and collaboration across service systems, as well as gaps in research, clinical expertise, and access to appropriate programs. So that was done in 2004, and I think that still exists. And their recommendations are to continue the dialogue across systems, to develop a joint research and data agenda, identify and disseminate effective models of collaboration, and develop a universal assessment tool and guideline for its use. And of course, to recommend changes in the state, federal programs, because that's the only way that we can bring change. So that's my quick answer.
Great, thank you. How about, I'm going to save it for Jim to be the last one to answer, but how about Dr. Ori? I know that Kaiser's been so involved in this integration of services. What are some thoughts you have in this area?
Thanks, David. You know, what an impressive array of services that we learned about today. And even someone like myself who's been in the field for a while, until I began participating in the planning of this symposium, I wasn't aware of many of these amazing programs and services. And so as I sat here and, tried to put myself in the place of our families, our clients, imagine trying to navigate all of these different services, trying to locate the ideal fit for your family member, for your client. It is a maze of different pathways and roadblocks and obstacles, even though we have so many amazing professionals dedicated to this field. What we have tried to do at Kaiser Permanente, as I mentioned in my remarks earlier, is we have tried to bring as many of our services in-house as we possibly can to create a centralized location so that our patients and our families can come to one place, deal with one set of people, and not have to get the runaround that so many of our families have to go through. And we've made some progress, but as you've heard our other speakers comment on, particularly Scott at the end there, we are facing massive shortages in qualified, interested individuals who want to do this kind of work. We have a staggering shortage of psychotherapists and psychiatrists. The figures across the country are just alarming, estimates of anywhere from 35 to 50% shortages of the trained professionals that we need to adequately serve our population. And particularly now in the pandemic era, it is even more difficult to hire people. So I would say that what we need to continue to commit to is reducing the amount of work and effort and energy that our families have to invest in getting the services that their loved ones need. We need to provide significantly more funding. I'm proud to say that over the last 10 years, Kaiser Permanente has invested tens of millions of dollars in Northern California to recruit and hire hundreds of therapists, but we have still a huge gap in terms of what we need to meet the needs of our patients. So this call to action and this collaborative work that we can do together can only move the ball forward.
Thank you. Mike, what are your thoughts on what is the one thing to improving integrated services in behavioral health?
Okay, well, one thing. Well,
just one.
The comments that I still saw in the chat were something that I dealt with 25 years ago, and that's where sometimes our two systems still see a person with two problems that don't come together. So people sometimes say, well, if they have regional center services, then they shouldn't be in the mental health system, or if they have mental health issues, then they can't be in the regional center system. And so to continue to work together, to let people know that just because someone has a disability doesn't mean that they don't also have depression, or just because someone has a mental health issue doesn't mean that they don't also have a developmental disability. What we are doing at regional centers to try to move forward with this is to change our models a little bit differently. We had an old structure that worked really well for a while, but we're seeing lots of different types of people come in. And that means that we need different types of homes that are specialized to work with people that also have mental health issues, and to be more flexible and to get away from some of the older models that worked at the time, but now need to be changed. And that's what we're doing.
The big message is behavioral health as a community resource is to work in collaboration with regional centers. And I think after today's message, we're hearing. Brian, what are your thoughts? And you're on mute, Brian.
Okay, my thoughts are similar to what I'm hearing Ori and Mike say. And Mike and I worked together for years, so he knows that we certainly have a shared vision of how we can work with, collaborate between regional center and behavioral health. And with regard to what Ori was referring to as access, we need to be able to create easy access for people who, right from the point of diagnosis, initial diagnosis, through the point of assessment and shared coordinated care. Anna, I love the things that you mentioned in your program about the array of services a program offers. So kind of having that centralized service that Ori referred to, and I know that Hope provides, is a good is helpful for clients to be able to navigate within a system sometimes. And then I think we need to have we need to get together on a regular basis, as we do in Santa Clara County, to talk about how we can share our resources across our systems, so we're not duplicating things, and so that we're adding what we can, and look at it as something where it's all of us adding something to help the client and their family. And so I think in training for we need more training. I was so encouraged to hear today about psychotherapists who are trained specifically in the area of being able to offer services for clients who have co-occurring disorders of intellectual delay and behavioral health needs. And also, I think it's good for us to have a case management component, because as we talk about in our systems meeting, so often we're finding areas where we need to look for more housing and more vocational access, because many of our clients, as I think Uday brought this to our meeting one time, we talked about the number of our clients who are not working, and our clients are just like everyone else. They need, they benefit from being able to work a job and have that sense of self-esteem that's associated with it.
Great. Senator Bell, I'm going to give you, Anna, we're going to have you be first answering the next question, but I want Senator Bell to ask this. From your point of view as worked as a senator and county supervisor, and just your role in California legislation and policy, what are your thoughts on how to integrate the service system?
Well, as a dad, okay, I'll talk about
and as a dad.
Okay. Going back, it would have been nice if we had a integrated diagnostic evaluation by the school system, the developmental system, the health system, together as one that everybody agrees on, and getting all those agencies, institutions together so that they all agree on a diagnostic evaluation, and so we can develop our individual plan and our individual education plan and all that together, so everybody agrees. So it would be helpful if some of the educators knew what the developmental plan was for my stepson, or the developmental center knew what was going on with the education system and the mental health and the healthcare. He had developmental disabilities, schizoaffective disorder, physical disability. So he had kind of a combo, like you say.
Great. Yeah, that's a great answer.
And I'm going to services, but I'm saying, as the earliest possible point in time in the person's life, there should be a start of a process of regular periodic evaluations that are integrated. If we want to start integrating, that would be a good place to start.
I like that. Yeah, I like that.
You can have everybody agreeing. It'd probably save a lot of money, I'll tell you that.
Yeah.
If one system wasn't going one way and the other system going another, and this overshadowing issue really struck a chord with me in terms of where I was, my experience as a dad was. So I would say the diagnostic thing, integrating it, having more professionals that we need. That Dr. Ori is right. We need, the workforce is so stretched, so very, very thin in terms of staff, in terms of the professionals. We need to just basically subsidize the workforce, education, the training. We have to pay for some of this.
Thank you, Jim. I appreciate that. Yeah, those are great comments. I like that idea. And if we can put a symposium together on web with 200 participants and 40 panelists, we can maybe cross-state manage. Arushi, I'm going to turn this over to you. Arushi, I'm going to turn this over to you. I know you have a question on that from the floor that you're going to ask, and we'll have Anna be the first to answer, and then we'll have let's see. Well, and then I'll just assign a couple others. Our ASL interpreter must end at 1:15, so we will conclude our symposium today at 1:15. Go ahead, Arushi.
Thank you, David. And this is a very good segue from integration to how can there be movement for the next steps. So a question that had come up was, is there cross-training available for mental health and ID professionals to meet the need of this dual diagnosis clientele? And what are we doing in an advocacy level, state level, basically in a macro and a micro level? So please take the floor. Anna, you can go ahead. David, Senator Bell, Mike, Brian.
Anna, how's cross-training going on? Is it happening?
Well, a good question. I mean, cross-training is an area in which we need to make some improvement, definitely, because I also heard Senator Bell talk about what is in our school system, which kind of curriculum are available for therapists that will actually serve a specific population that is ours. We could start also from there, because what happened in my experience, our therapists come out from school, but they have all the theory that they can use for neurotypical rather than, with the part. So we do a lot of in-house training to help the workforce to be ready. There is also an association, a national association, the NAD, National Association of Dual Diagnosis. And there is also a European Association of Dual Diagnosis. And there are several research done by these two organizations that have as an interest this, at least from a training perspective, a research perspective, to integrate the two systems, at least from a theoretical point of view. Then the challenge is how to actualize in practice this effort that we are all trying to do.
Great. Gabby Oliveras, do you have some insight about cross-training?
Yeah, so I can speak more on a local level what we're doing. So in 2019, autism became a diagnosis that was Medi-Cal billable. But unfortunately, we were already seeing people in our criminal justice system that we weren't screening and referring. So what we're doing actually is tomorrow with all of our criminal justice providers, our system providers, that includes probation, pretrial, state parole, we're actually having a joint training. And some of the participants here are actually joining us in that training because unfortunately I've done several lit reviews. I can't really find literature and information on and screening tools that are effective or have been used with jail involved populations, which is really unfortunate because I think, when it's not caught early on, the adult becomes very skilled at hiding the disorder. And so what we're really trying to bring is more awareness to Santa Clara by adding screening tools. We've worked with Hope Regional Center on what screening tools should we add so that there is early identification. People travel through our justice system, booked at the jail, come through our collaborative courts. We're quickly able to identify through those screening questions. We're requesting collateral information from the state prisons, the jail. Do you know if this person, participated in any, school-based programs? Was it early identified that this person, you needed additional assistance through schooling, anything like that? So that's what we're doing. The other thing that we're really looking at is we're recommending a current overhaul of our system. And we really want a gap analysis to look at what treatment options are available and what we can do to better enhance our system when we do find out that we have someone that has autism, IDD, that we're providing the appropriate care if we are unable to link that person to SARC or HOPE, that we're building in those resources within behavioral health. So we're dealing with the substance abuse, the mental illness, and whatever the IDD is. We're really gearing up our system to be a better care provider for this population that we really feel has been lost or wasn't properly diagnosed or identified early on in childhood.
Thank you so much, Gabby. Well, I wish we had more time. In the old days, we used to meet in person and have all-day symposiums, but we sure don't today, do we? Let us, again, I thank everyone for being here. Really great information. You'll be hearing from us soon. Thank you all very much for today's symposium, Bridging the Gap. Bye now.
Bye.